everyone, and welcome on this beautiful Saturday morning. My name is Eric Singhi. I am a thoracic medical oncologist and assistant professor at the University of Texas MD Anderson Cancer Center. Welcome to Cancer Grace Lung Cancer OncTalk for 2025. Again, thank you for spending your precious Saturday morning with all of us. Really excited to be able to talk and have this open conversation that's oriented for patients, oriented for your loved ones, all about lung cancer care. And you're going to have access to some amazing multidisciplinary experts who are focused on treating patients with lung cancer every single day. Before we get started, I really want to thank our event sponsors for today. So Takeda, Janssen, Daiichi Sankyo, and Regeneron, thank you so much for investing in patient education. Your efforts are really recognized and important. We have an incredible lineup today. My job is to navigate us through, make sure you guys have your coffee refueled, really making sure that we're all learning together and having great conversations. So with that, I would like to first welcome a medical oncologist and dear friend of mine, Dr. Fauzi Abu-Rus. He is a thoracic medical oncologist at Henry Ford Health in Detroit, Michigan, focuses on clinical trials and biomarkers. He's really focused on improving the outcomes for patients specifically with squamous cell carcinoma. And his translational research has really been recognized by multiple organizations. He actually won the 2023 ASCO Young Investigator Award, also the You Can Survive Foundation Award. Nameless numerous awards, and is an incredible human. So with that, I want to welcome him here to talk a little bit about some of the newer treatment options that we have for patients with lung cancer, specifically antibody-drug conjugates, ADCs, bispecifics. What does that all mean? And so with that, Dr. Abu-Rus, I'd like to welcome you to take the stage.
Thank you so much, Eric, for the kind introduction, and thank you, Grace, for the invitation. I'm looking forward to discussing newer treatments in lung cancer with everyone here in the audience. Let me share my slides. Can you, Eric, let me know if you can see my slides in a presentation mode?
It's working its way there. Let's see. There we go. That's perfect.
Excellent. Okay, so hi everyone, I'm Fauzi Abu-Rus. I'm a thoracic medical oncologist at Henry Ford in Detroit, Michigan. Today I'll be talking about newer types of treatment for lung cancer. So specifically, I'll be talking about antibody-drug conjugates and bispecifics. These are my disclosures, and this is the agenda for today. So we're going to talk about ADCs and bispecific antibodies. We're going to talk about the components and the structure, mechanism of action, mechanism of resistance, talk about some examples, and then future perspectives. Okay, so let's start with ADCs. So what are the components of ADCs? So let's say that you're in your kitchen on a Saturday morning and you want to cook up an ADC. What do you need? What are the ingredients that you need in order to make an ADC? So in order to have an ADC, you need a target, right? Because it stands for an antibody-drug conjugate. Actually, let's start with the antibody. You're going to hear me say antibody today like a lot of times. So we need to understand what is an antibody. So an antibody is a protein that has two arms that bind to a target. And then these are what's called the Fab or the FAB portions. And then you have the FC portion. So what is the FC portion? It's basically the part of the antibody that is used to activate the immune system. So you need that antibody, you need the target, right? And this way you have a functioning antibody. And then in order to have it as an ADC, you need to conjugate chemotherapy to it. So this is basically the payload. And then you need a linker between the payload and the antibody. Joshua Sabari, who is at NYU, once called it chemotherapy on a stick. And since then, I can't think of it in a different way. So it's basically a stick, which is the antibody, and there is chemotherapy on it. Or in other ways, you can think about it as a chemo mailman, right? So you have your mail, which is the chemo particle, and the mailman being the antibody, and then it delivers the mail to the cancer cell, hopefully in a very specific way. Okay, so let's try to break it down and talk about each of these ingredients. So starting with the antibody, there are many types of antibodies, IgG, IgA, IgM, IgE. Each of them has its own characteristics, but the most widely used antibodies in ADCs are IgG. Why? Because they have higher specificity and affinity to the target antigen that you're trying to basically target. They have a favorable PK, which means that the body processes the IgGs in a very favorable way, making it short, a reasonable half-life and a reasonable basically like the window where it's the efficacy window where it's the ratio between the efficacy and the toxicity is very favorable. It has minimal immunogenicity, which means that it's not gonna be targeted targeted by the immune cells and destroyed once it enters the body, but at the same time, it's able to elicit an immune response through the FC portion that we talked about. And then because they're small compared to other types of antibodies, such as IgM, the cancer cell can internalize that IgG, and then it can kill the cancer cell from the inside. And we're going to talk about the mechanisms of actions in a little bit. Okay, the second type or the second ingredient of the antibody drug conjugate is the antigen. It's not technically a part of the antibody drug conjugate, but it's a very important component for the ADC to work. So what is an antigen? Antigen is a protein that is expressed or a molecule that is expressed on the cancer cell, right? And as you all know, in cancer, there is really no black and white. So this molecule can be expressed also on normal cells, right? Or most of these or all of these molecules are expressed on normal cells as well as the cancer cells. But for us to choose a winner target, we need that target to be preferentially expressed or in higher levels on the cancer cells, so that the effects are mostly on the cancer cell rather than the normal cell. And then that protein or that target or that antigen needs to be important to the cancer cell, right? Because we're trying to target the machinery of the cancer cell and kill it. Then that protein or antigen needs to be very important in the cancer cell machinery. And then when you have your antibody, right, and then you have your mailbox, or you have the package, I mean, that you're trying to deliver, which is the payload. We're going to talk about it next. You need to attach it to the antibody. So you have your mailman, you have your package, you need to attach them to each other, and then you have the linker, or basically the glue. Some glues are the ones that we used to use in school. They don't work, so these are the cleavable linkers. But some of them are super glue. They work really, really well, and these are the non-cleavable linkers. And each of them have their own pros and cons at the same time. The cleavable linkers, they work in a way that it's good enough to attach the chemo to the antibody, but then because they're cleavable, they can be released in the bloodstream on their way to the cancer cell, and that can cause some side effects. Whereas the non-cleavable linker, they bind the antibody to the chemo, or the chemo to the antibody very well, that in order for it to work, the cancer cell has to destroy the whole complex or digest the whole complex for the chemo to be released. These both of them have their own technical pros and cons, but these are the two types of linkers or glues that we have: the cleavable and the non-cleavable linkers. And then we have our payload, or the chemo package that the mailman is trying to deliver. And this is basically, very small nanoparticles of chemotherapy, but that chemotherapy has to be potent at these very low or nano concentrations, and has to be able to be conjugated, right? So you're not going to choose a chemotherapy that cannot be glued to the cancer to the antibody. I can't claim that I know exactly how that how that works, but I'm sure our scientists and pharma industries, when they're trying to design an ADC, they think about the chemo that is amenable to conjugation to the antibody. And then usually the types of these chemotherapies that are conjugated to the antibodies work by damaging the DNA of the cancer cell, or managing the tubules that the cancer cell use in order to replicate its DNA. So it targets the core machinery of the cancer cell itself. And then there is a very important principle that we all have to understand when we're talking about ADC, and it's called DAR, or drug antibody ratio. So it's very simple. So it's basically, what is the ratio between the chemotherapy particles and the antibody? So how many chemotherapy particles are linked or conjugated or glued to that one antibody? We always have one antibody particle. The DAR is how many chemotherapy particles are attached to it, and that affects our efficacy as well as toxicity. So higher DAR means higher efficacy, but possibly higher toxicity. Lower DAR means lower toxicity and potentially lower efficacy. So the most approved ADC have a DAR between 2 to 8. So either 2 to 8 particles of chemotherapy are attached to that one antibody. So these are the components that we need in order to make our own ADC. We need the antibody, the chemo, the linker, the target, and then we need to understand the DAR, or the drug antibody ratio. So how do ADCs work? So what is the mechanism of action for antibody drug conjugates? We have a few, but just to name the most important ones. Number one is the bystander effect, which means that the antibody drug conjugate is rolling around in the circulation. It finds the target, it binds to the cancer cell. The cancer cell will swallow it, thinking it's a good thing. because it binds to a very important part of the cancer cell. And then when the antibody-drug conjugate releases the chemotherapy inside the cell, the chemotherapy particle can go around in the environment, killing the neighboring cancer cell that might not necessarily express that particular target. And then number two is what we call ADCC, or antibody-dependent cell cytotoxicity. And this goes back to the FC portion that we talked about in the first one or two slides. So when the antibody binds to its target, the FC portion is still available for immune cells to come and bind and also kill the cancer cells via immune activation. Number three is the antibody antigen binding. So if you guys remember when we described the antigen, we said that it has to be very important for the cancer cell machinery. So when the antigen or the ADC binds to the antigen, it gets internalized or swallowed, thinking it's a good thing. So that by itself disrupts the cancer machinery and lead to kill cell, or basically the dying of the cancer cell. And then number four is receptor blockade. Very similar concept. You know, these receptors are very important. So when you block them, they can't interact with each other. So that affects the signal transduction downstream from that receptor, and then also leads to apoptosis, or basically death of the cancer cell. So of course, as anything else, there is always resistance, or the cancer always can develop resistance to these ADCs. So what are these mechanisms of resistance? Number one is target antigen related. So the cancer will learn that, you know, we're trying to target that antigen, so it just stops expressing that target. So down regulation of the expression of that particular protein or target. Number two, it can do what we call decreased internalization. So we explained that when the ADC binds to the target, the cancer cell will internalize it. So it will just stop doing that. So, you know, stops producing the enzymes that internalize the proteins, and will increase the production of the enzymes that causes efflux, or basically kicks these proteins out. Number three is lysosomal dysfunction. So when the cancer cell swallows that ADC, in order to degrade it, it creates something called lysosome, and it's basically an acidic bubble that breaks down the proteins. So that bubble, the lysosome, just becomes less acidic. When when it swallows that ADC, it just stays there and it cannot release that chemotherapy. Number four is payload related, which means that the cancer cell can develop resistance to the chemotherapy that we have attached to that ADC. And lastly, you know, some other less common mechanism of resistance that I think we talked about very generally so far. So what are examples of ADCs in lung cancer? We have Dato-DXd, which is approved in EGFR. We have Teliso-V, approved in patients with non-small cell lung cancer that express MET in higher level. We have, I don't have it here, but there's also T-DXd that is approved agnostically in all cancers, but also there is an approval in HER2 positive non-small cell lung cancer. And there are some other, you know, promising ADCs that are coming to the market, such as IDXd in small cell particularly. So how can we improve? What are the future perspectives? How can we do better in ADCs? Number one, we can, you know, try to change the structure of the ADC, making it bispecific, trispecific, a lot of things. We can work on the payloads, not only chemotherapies. We can attach maybe some immunotherapies to it. We can, you know, the dual drug, or maybe the novel linker or conjugation. So play on that, you know, DAR, play on the linker, play on the number of chemotherapies that we're attaching to the ADC. There is a lot of things that we can do. We can also develop new targets, right? We always come up with new targets as we understand cancer or lung cancer more and more. We can develop biomarkers for the ADCs that we have right now. Try to understand, yeah, which patient population they work better for. And lastly, novel combinations. Combine them with immunotherapy, with targeted therapy, with other types of treatments that are coming to the picture. Okay, moving on to bispecifics. Very similar structure when we're talking about the antibody. But the idea here that instead of having the antibody directed to one antigen, bispecifics can attack two targets at the same time. So if you look at number A, you know, you look at the Fab regions, the two arms, they are the same colors, meaning that that antibody binds to one target. And then if you look at C, at the figure here on top that is marked C, that the two Fab regions are in different colors, which means that they can bind to two targets at the same time. And I don't want to get too technical, but also the FC portion, we can also play on it and try to make it even more immunogenic to activate the immune system. So bispecific antibodies, nothing is attached to them. It's just an antibody that binds to more than one target. The analogy that I always use is basically like the fork that we use to basically eat steak, right? You put the steak on one side and then the potato, and this is where you hit the right spot. For my vegetarian friends, you can think about maybe like falafel and hummus or something like that. Trying to hit the right spot by attacking more than one antigen at the same time. So how do bispecifics work? Very similar principle to ADCs, but there is something here that I want to discuss. Let's start with the obligate bispecific antibody. So you have that antibody that binds to two targets, but in order for it to work, you have to bind both targets at the same time. So it's obligate bispecific antibodies. And then you have combinatorial bispecific antibodies where you have two targets, right? But if you attach them or if you bind to them at the same time, that's great. But it will also work if it binds to each target independently. And that's, similar to amivantamab that we're going to talk about in a second. So let's talk more specifically about the types of bispecific antibodies, from a mechanism of action standpoint. So we have bispecific antibodies targeting dual immune checkpoints. So we don't have anything that is approved right now, but there are a lot of these bispecific antibodies that are in development. So one arm will bind to our PD-1 or PD-L1, similar to. So basically, let me give you an example. Think about this as ipi and nivo, or ipilimumab and nivolumab in one antibody. Ipi is an immunotherapy that targets CTLA4. Nivo is an immunotherapy that targets PD-1. So put them in one antibody. Instead of having two drugs, you just put them in one drug. So that leads to more immune cell activation and then hopefully more immune effects on the cancer cell. We have some bispecific antibodies that target immune checkpoints such as PD-1 and then angiogenesis. Angiogenesis are the proteins that are important in the development of the baby blood vessels to and nourish the cancer. And an example on this is ivonescimab. So it's a drug that has a lot of buzz. We're all hoping that it would deliver on the promise. The results look very, very promising. So one arm binds to PD-1, the other arm binds to VEGF. The idea behind that is binding both at the same time will lead to higher immune response, and then you attack the cancer in two different ways. And then we have the bispecific antibodies that target signal pathway blockade. This is your amivantamab, which is approved in EGFR positive non-small cell lung cancer. You have basically one antibody binding EGFR, the other binding MET, and you just put them in one antibody, creating amivantamab. So you can bind the MET and the EGFR at the same time, but even if you bind each of them independently, the drug will still work because these two pathways these two proteins are very important to the EGFR positive non-small cell lung cancer. And then we have our BiTEs, or bispecific T-cell engager. Balaj Helmus, or Dr. Helmus, always uses the analogy of the matchmaker. So you have your antibody or tarlatamab. It tries to bring the CD3 positive T cell, so the immune cell, closer to the cancer cell. And if the spark happens, right, this is the response. Sometimes it can be overwhelming, causing side effects, but it's basically the matchmaker for small cell lung cancer. You can target your T cells, but you can also target other types of immune cells, such as NK cell and some other types of T cell. So what are some examples on bispecific antibodies in lung cancer? I think we talked about them. So we have our amivantamab, right? We have our tarlatamab. Amivantamab is approved in EGFR positive non-small cell lung cancer in the first line and the second line. We have tarlatamab, which is approved in small cell lung cancer. That's an example on BiTE, bispecific T-cell engager. And ivonescimab, it's not approved yet. It's approved in China in some indications, but here in the US, not approved yet. But it's a very promising drug that binds to PD-1 and VEGF, the baby blood vessels protein, at the same time. So what are future perspectives in bispecifics? How can we make them better? Let's start with this cycle from A and then go to E. So number one, patient selection. So biomarker discovery. How does these drugs work? What are the important proteins? How can we select patients that might benefit more from these drugs? The number two, I can't see it here from my screen, but I think we're talking about the dose optimization and trying to manage the efficacy and the toxicity, or optimize the efficacy and manage the toxicity at the same time. C is trying to enhance the clinical efficacy by combining it with other chemotherapies, immunotherapies, other targeted therapies, something that makes sense to the cancer cell. And then to try to overcome the resistance, right? Like we talked about, there's always resistance, to try to predict it and then overcome it. And lastly, try to overcome the immune escape. So all of these drugs that we talked about activate the immune system, but sometimes the immune cells will get exhausted. They will get burnt out and tired. So we need to learn how to overcome this. So that's my last slide. I think I'm right on time. So the take-home messages ADCs and bispecific antibodies have revolutionized the way we treat cancer, not only lung cancer, I think all cancers. Number two, you guys can think of ADCs as a chemo on a stick or the chemo mailman. You can think of bispecific antibodies as the fork with two prongs, one for a steak, one for potato, or one for hummus and one for falafel. And then these both mechanisms of actions are designed to be very specific to the tumor-associated antigen in order to potentiate the effect on the cancer cell and be as specific as possible. And then scientists are not stopping here, of course. Many novel forms of ADCs are coming. Many novel forms of bispecific antibodies are coming to the clinic. So stay tuned. And with that, I would say thank you guys so much. And I'll hang around for the panel, of course, and the Q&A session.
Thanks, Dr. Abu-Rus. Really appreciate it. We wanted guys to start off with a lot of hope here, right? So clearly you've learned that there's a lot of new classes of drugs being developed for patients with non-small cell lung cancer, even small cell lung cancer. We're seeing some of these drugs in that space too. So a lot of hope, a lot of excitement. We'll tap you back in, Dr. Abu-Rus, very shortly for our panel. You guys keep asking questions. We're going to take all the questions at the end that you guys have submitted and go through them together in the entire panel. But we'll do a little mini panel session in just a second. So thanks again. And thank you for the shout out for hummus and falafel. As a vegetarian, I appreciate that. So more than just steak and potatoes. All right, to keep us on time, I'm really excited to next introduce Dr. Jeff Reichman. He is from West Virginia University. He's a radiation oncologist with a background in medical physics, guys. He's incredibly brilliant. Some of the smartest physicians that I work with are radiation oncologists. He provides care across all cancer types, including non-small cell lung cancer. And what he's really focused on doing is using digital tools and platforms to simplify those really technical aspects of radiation oncology to help clinicians focus on what matters most, and that's caring for patients. So he's going to talk about radiation specifically for patients with unresectable non-small cell lung cancer, stage 4 disease. What are we doing? So with that, Dr. Reichman, I'm really excited to have you here.
Thank you for that kind introduction. I'm going to share my screen here. Um, and okay, can you see my slides?
Yes, we can.
Perfect. So again, I'm Jeff Reichman. I'm an associate professor at WVU Medicine, and today I'm going to talk about radiotherapy for people with metastatic non-small cell lung cancer. Now, I do want to kind of start this the way I start every single consult. It's not okay that you and your loved ones are dealing with this, and everything about this is a traumatic experience. And so I think the emotional component of care and trauma-informed care is so important. I wanted to put in a few slides on it, but I kind of just felt it was appropriate for me to really just stick to the topic of radiotherapy. But I feel like both of those things are fair to say. It's not okay you're dealing with this, and everything about this is traumatic, but we can focus on the bright spots together. So, some disclosures, none of which are relevant to this talk, but a bit of a shameless plug. But based on the prior presentation on ADCs, I'm working on an application to help radiation oncologists and treatment teams, which will be presented at the European Society of Therapeutic Radiotherapy and Oncology in Stockholm next year. It's an evergreen review to help determine whether medicines such as ADCs should be held during radiotherapy, depending on site treated and number of treatments based on things like mechanism of action or how medicines work and biological half-life or how long they stay in the body. Although apps are helpful, in reality, these are multidisciplinary decisions made by your local oncology team. Chance favors a prepared mind, but in today's world, it may favor the mind that can find the relevant information most efficiently. So the resources above is and always will be free to use to help clinicians spend less time searching for technical details and more time with patients and their families outside of work. My biggest disclosure is that I'm a radiation oncologist and I'll do my best to temper my own biases. Also, full disclosure, again, as Eric had mentioned, unlike the other esteemed panelists, I am not a lung-specific oncologist. Instead, I'm a generalist who treats a variety of cancer and non-cancer conditions with radiotherapy. So, radiation therapy uses carefully targeted energy to damage cancer cells so that they can no longer grow. It is not like nuclear accidents or comic book radiation. It's a safe medical treatment delivered with precision. And so there's three different types of oncologists: the surgical oncologist, the medical oncologist, and the radiation oncologist. And radiation oncologists work closely with medical oncologists and surgeons as equal partners in your care. So radiation has really come a long way. We've only really known about it for a little over 125 years. Actually, it's coming up on 130 years next year. And so how has radiation evolved? Well, Here, what we're seeing is an X-ray, and we used to use these China markers or wax pencils. It was on radiation, every radiation oncologist's desk to design these fields. And we'd just be able to shoot from the front and the back. And sometimes we would gauge the dose based on skin reaction for deep-seated tumors because we could only do so much on paper, right? But I'm not trying to knock on historic techniques. They're still tried and true. And often we do simple plans are best, which we'll dive into. And we would actually like take calipers and like measure the thickness of tissue that we were treating to calculate how much radiation to give. So it's not like we had like 3D printers back in the day to do stuff like that, but I digress a little bit. So now, presently, this is a PET scan that shows a lung tumor in a spot in the bone on a PET CT. They kind of are bright in areas where the tumor is using energy, but it's also kind of excreted through the kidneys and the bladder. So that's just normal activity in the kidneys and the bladder. But that's a lung tumor in a spot in the bone. And now just think of cell phones over the past 10 years as well. Technology's come a long way. The same could be said for advancing medical technology and radiation. So we used to plan by hand, and now we use computers. So this is an example of historic lung radiotherapy. I think that says 72 right there. And so we just treat from the front and the back. And this is from Learning Radiology, a fantastic website. But really, this is what it was called, square pneumonitis. So what's pneumonitis? Pneumo means lung, and itis is inflammation of the lung. So in this case, the patient had cough, shortness of breath, sometimes low-grade fevers associated with this. But in time, this resolved, and this is what it was called, square pneumonitis. We simply don't see this today. But in the long run, this settled down and the patient was able to breathe better. So there's short-term side effects and long-term side effects. And this is kind of a good example of a short-term side effect from radiation. Now, sometimes the simple treatment is sufficient, where we kind of treat from one side and then treat from the other. But there's a lot under the hood with something simple for this. Like this is basically whole brain radiotherapy. Sometimes we still use this for emergent situations. A simple setup is often a good setup. But there's more under the hood. So, like for example, I'm trying to avoid medical jargon, but radiation has divergence. So, what is divergence? Well, think of a laser pointer. So, if the exit of the laser pen, it's the same size as it would be, across the room. That would mean there's no divergence. But radiation's like a flashlight. If you're able to visualize it, it would kind of diverge, right? And so here we're actually matching the divergence to avoid exposure to the lenses in the eyes to decrease the risk of radiation-associated cataracts. It's a little bit more complicated where we kind of tilt things one way and then we treat from the other side and we just make sure that there's no divergence into the lenses here. So it may look simple, but it can actually be somewhat complex even for simple treatments. Now, this is a spot in the left hip. This is like we're looking up from the foot of the bed and you're cut like a slice of bread. And so this is on the right hip, and this is actually the left hip. So things are flipped. So if you're ever seeing something in the doctor's office, that's how it looks. So this is the left hip, and just treating from the front and the back. So sometimes the simple treatment is sufficient. For broader coverage, lower doses, usually 1 to 10 treatments, and the goal is symptom relief or perhaps even prevention of symptoms in high-risk areas. Other times, treatments are more complex. I actually have a tattoo of this on my back resembling quality of life. This is called VMAT or volumetric modulated arc therapy. There's so many abbreviations in this field. But in general, it's fancy radiation. So it's more pinpoint, often higher doses in 1 to 5 treatments, and the goal is long-term local control. But as it rotates around, no human could do these calculations. This is done by a computer. But as it rotates around, it's pointing in, and there's at least 40 independent motors shaping the beam as it rotates around. There's infinite solutions to these complex problems. Now, this is the right lung tumor from the PET CT that was shown earlier. This was actually done in 15 treatments because, and I call it the MD Anderson special, actually, a treat per Gomez. But sorry, I don't mean to use jargon. But basically, this was 15 treatments. So sometimes it's not 5 treatments or less, but often when things have spread, we like to do more abbreviated treatments. And so it's highly targeted and designed for long-term local control. Now, same patient, left hip, and this is just 2 treatments. And again, the beam's pointing in as we're treating, and this was for symptom control here. But those were the only two spots, so we kind of felt it was justified to be a little bit more aggressive. So, in summary, traditional radiation versus SBRT, which we're going to talk about in the next slide a little bit. Traditional radiation's broader coverage to lower doses, typically 1 to 10 treatments or fractions, and the goal is symptom relief. Whereas SBRT or stereotactic body radiotherapy is more pinpoint, often higher doses, often 5 fractions or less, but not always, like that lung example, which was 3 weeks. And the goal is often long-term local control and symptom relief sometimes too. So, what are we saying? And this is from my buddy Neil Newman. When we say SBRT, SABR, or SRS, they're essentially the same thing, except for stereotactic radiosurgery is specific to the brain. But these are all kind of saying the same thing. And again, I'm trying to avoid the use of jargon, but I think it's important just to be aware of some of the jargon that's out there. But they're highly precise forms of radiation that deliver a very high dose directly to the tumor with an extremely sharp dose drop off in surrounding healthy tissue. So, in the past, advanced lung cancer was treated with medications alone. Now, research shows that adding focused radiation to small areas of cancer can improve control of the disease. So, what local therapy options exist? Really, mainly, generally speaking, perhaps hopelessly oversimplified, but there's surgery, radiotherapy, and ablation. So, for surgery, it provides pathological information and high rates of local control. Some cons may be that it may be invasive or could be associated with longer recovery time. Sometimes things can be outpatient as well. And then from radiotherapy, it's non-invasive. It's often associated with high rates of local control and may be associated with shorter time off systemic therapy. Sometimes we have to hold medicines though, so there's always a catch and it's complicated. There's no pathological information. That's one of the downsides. And then for ablation, it's mildly invasive as compared to surgery. It's typically a single procedure. And cons is it is associated with inferior local control for larger tumors, generally speaking, for tumors greater than 2 to 3 centimeters. Now, radiotherapy is the most common form of local therapy for metastatic lung cancer, and it is the least invasive, but anatomical factors may favor one modality over another. This is informed decision making through a multidisciplinary team. So, why do we talk about local therapy in metastatic lung cancer? Some people, like Ian Tannock, say that it's akin to closing the barn door after the horse is bolted. What's the point, right? Once things have spread. And so there are many reasons why people with metastatic lung cancer may come to the radiation oncologist. The two main umbrellas are for palliation or relief or prevention of symptoms, or for aggressive treatment. And so in this example, this gentleman has a spot in the lower back that's causing him pain and came to the office for treatment of metastases. And then this is an example of someone who may have breathing difficulty, and the goal would be treatment of the primary tumor to help keep the lungs open, to keep them breathing and hopefully off of oxygen or from requiring additional oxygen. So those are kind of the two main divisions of palliation. The same thing for aggressive treatment as well, treating the spots outside where it started and then treating the original spot. We start to think of that when folks are in good shape and they only have a few spots, just generally speaking, though. It really depends on the individual patient. Now, in terms of metastatic disease, there's really like two main buckets where things are initially spread, where we find the spot, and then there's spots elsewhere, whether that's in the lung or outside of the lungs. And then also, there's when metastases develop at recurrence. Here, this resembles a primary tumor treated and then new spots later on. But they're largely treated the same. So what does oligometastatic mean? Oligo is the Greek stem for few, and poly means many. First, for lung cancer, here are the definitions, but basically, if you can count them on one hand, it's considered oligo or metastatic. But really, the key message here is limited spread versus widely metastatic. But some people only have a few areas where the cancer is spread. But it's kind of controversial. We're moving away, generally speaking, from number of sites to maybe volume of disease or treatable disease burden. So again, just because we can count it on one hand doesn't mean that we might not consider different types of radiation that may be a little bit more aggressive than traditional radiation, as long as we feel we can treat all of those spots. But again, Things vary on a patient-by-patient basis. So what do we know about stereotactic radiation for limited cancer? Basically, the safety is about 1 to 2 folks have short or long-term side effects out of 100 people in the short term and the long term. Effectiveness wise, tumor control at 1 year is about 95%. And the key point here is that it's safe and works well to control tumors, but it's highly dependent on location, such as if things are in the abdomen around small bowel or the stomach, it's really complicated to treat. And it really, really depends on the site in terms of safety and also the dose selected and also the volumes that the radiation oncologist draws. It's very tough. You know, some of this is gut feel in terms of how safe we feel that it is, depending on the site and the patient and other things they have going on in their life. So these are just hopelessly oversimplified numbers, but generally speaking, it's safe and works well to control tumors. So, timing of local therapy. When should we do it, if we do it, right? And the focus here is on folks where we might want to be a little bit more aggressive when there's just a few spots. So, there's upfront treatment and treatment later on. For upfront treatment, it can prevent problems at high risk sites. It's best if spots can be treated safely and quickly. Downsides are it may delay or prevent receipt of medicines, and things may spread further without the appropriate medicine. So we can boost the mileage of medicines with local therapy. When we treat early, we can reduce the amount of cancer and improve the duration that you may be on a specific medicine. Sometimes we also treat later on. Pros of this is that we ensure the receipt of medicines known to improve how long people live, and it may shrink areas too high risk for local therapy up front. So it helps for me to feel more comfortable to maybe give a little bit extra radiation, and I'd feel safer doing that if it was maybe half as big as or a third as big as it originally started. The downside is there might not be benefit if the medicine isn't as effective or there are no more medicine options. So it's a balancing scale. You know, medicines alone may be convenient with less adverse effects, but local therapy could possibly introduce additional adverse effects. So once the spot starts growing, we can do deferred radiation or local therapy to take care of the spot so you can continue the same medicine. And we still don't know if it's better to switch the medicine or add local therapy and stay on the same medicine. It's highly dependent on each patient. So does the spot go away after radiation? Let's talk about following up after radiation. Radiation works slowly over time. This is before, high precision radiation. 3 months later, it looks like a scar. And here I'd start to sweat a little bit, and where we see a little bit of increasing consolidation or, it's growing a little bit as compared to this scar. Now, short-term CT is what I would order, not a PET CT here. And look what happens over time. Again, 95% of the time, like the long-term local control is durable with effective doses. And so this is a reassuring pattern to me. It might look like gobbledygook, but I've looked at like thousands of these scans before, and we see this scar tissue all the time. And just because there's scar tissue, it doesn't mean the cancer is active. So understanding scans after treatment, the PET may look bright for many months after radiation, especially in the lung. That's why I personally like to avoid PET CTs within 6 months after lung radiation, unless it's necessary, or we're looking at spots outside of the lung that didn't just receive radiation. It's important to correlate follow-up imaging with where and when and what dose was delivered, and your radiation oncologist will help interpret scans so we may avoid unnecessary worry or treatment changes. So guidelines do support local therapy. National cancer guidelines say that local therapy should be considered for limited metastatic disease or people with a few spots of cancer who are otherwise doing well. It's also indicated in the setting of non-small cell lung cancer for people with limited progression while on medication, and then also for symptom relief and prevention of symptoms in high-risk areas such as around the windpipe or around the spinal cord. A lot of times we don't feel super comfortable to watch those. And so multidisciplinary approach is recommended. Now, on the next slide, there's going to be a lot of clinical trials that are ongoing. So I just want to preface with that. It's probably the most dense slide of this presentation, but I do think it talks about a lot of important studies going on. And so 2 to 3% of global oncology research spend is spent on primary radiation oncology questions. So a lot of these are collaborative group studies, but it's really fantastic that this work is being done. So Saber Comet 10 is for people with up to 10 sites. Remember how I was saying earlier, it's not just about counting on one hand. This is led by David Palma, and the early results will be reported next year. These are for folks that have a treated primary tumor, but also it includes all types of histologies. Now, there are some here that are specific to lung cancer, but these are the Saber Comet trial is like a landmark study, and these are the follow-up studies, and most of these are phase 3. I'm very excited about these results, and we'll have to see, right? Several key questions remain. But this allowed up to 10 sites, and it will be reported next year. I think Saber Comet 3 will be reported in the next 2 to 3 years. It opened up after 10. Now, Saber Sync is really interesting. It's an intact primary, and so that's for folks that present with a untreated spot in the lung and metastases. And interestingly, rinse and repeat radiation is allowed, forever essentially, to help folks stay on the same medicines. And speaking of which, CURB-2 is a study about when spots show up later on. Do we switch the medicine or do we treat the spots that pop up? So that's an interesting study. And lastly, I just want to call our attention to ARREST-2. That is for polymetastatic patients that don't really have any other medicine options, and they want to have a break from standard medicine or no further lines of therapy. And they use stereotactic radiation to over 90% of targets. It's wild. I've seen the plans for these. But that's, I think, one of the new frontiers where we might be changing from number of disease sites or number of spots to treatable disease burden. Now it uses a little lower dose, but anyway, I just wanted to mention that, and several questions remain. So at the end of the day, local therapy can reduce pain, prevent problems at high-risk sites. It can delay switching to tougher or less effective medicines, and it can improve or preserve quality of life. And it occasionally can give long-term remission in very select cases. The take-home points is that radiotherapy is precise and safe. It helps control cancer in targeted areas, and it often extends how long a medication may work. It's usually completed in just a few treatments, and we'll make decisions together based on your goals and values. And so that's it for me. Sorry, I think I went a little bit over, but thank you so much for your time.
Thanks, Dr. Reichman. No, you were right on time. This is perfect. Everyone is doing great this morning. We're educating, we're engaging, we're empowering, so really appreciate it. I'm going to ask Dr. Abu-Rus to come back on, and we're going to have a mini panel for about 15 minutes here. We're going to tap into some of the discussion points that you both highlighted. So radiation oncology points for patients with unresectable stage 4 disease, and then these newer therapies, ADCs, bispecifics. So I will kind of do a round robin and go back and forth between Dr. Abu-Rus and Dr. Reichman. Dr. Abu-Rus, you talked a lot about these mechanisms of action, how these drugs are working, how they're different than just standard chemotherapy, different than immunotherapy. So I really like how you said chemo on a stick, right? One of the hardest things I think is when patients come to clinic and they're trying to understand the drug that they're going to be on. Tell us a little bit more about how you actually explain it in clinic, like maybe one or two sentences, their caregivers there, their families there. But what does an ADC boil down into like one or two sentences?
I can't claim any credit for the chemo on a stick. It was Joshua Subari's description. But when I describe it in clinic, I always say that we're trying to use targeted chemotherapy because at the end of the day, it's chemotherapy, but it's delivered in a targeted fashion. And I try to explain it that what we're trying to target is a very important protein or molecule to the cancer mechanism that, the science show that it's more expressed on the cancer cells rather than the normal cells. And then I build on that saying that there will still be some expression on the normal cell, and that can result in the side effects. And then, as you all know, each ADC has its own side effect profile. So then I talk about that and try to explain it as much as possible.
That's perfect. And Dr. Meera Patel is going to be coming on a little bit later, medical oncologist, talking about biomarkers and how we really try to personalize treatment for patients with lung cancer. You hinted a little bit about finding a target and using this targeted chemotherapy to kind of direct and fight the cancer in that way. Do patients need special testing then to see if an ADC will work for them?
It depends on the ADC and the approval, right? the science, shows that yes, the more of that target that the cancer cell that you have, the more benefit that you will gain. But unfortunately, that's not always how, this translates into human studies, right? In the lab or the cell cultures, yeah, that showed, but in human studies, it does not translate all the way. So when we're talking about, for example, telisotuzumab vedotin, so that was, or even TDXD, the approvals for these two ADCs in in lung cancer or in cancer in general for TDXD depends on the level of HER2 in TDXD or MET in lung cancer. So if the patient has 3 plus or more of that protein on their cancer cells, then they qualify for that protein. So for these two examples, yes, you have to test for the target in order to see if your patient qualifies for that ADC.
Yeah, that's really helpful. So it sounds like there's some drugs where you have to look and
Yes.
see if there's a lot of protein being expressed by the tumor so that it can go after it. And then
Yep.
there's some drugs where you don't need to test. So it really just depends. And the testing is different than next generation sequencing or gene testing, right? So there's protein testing, there's gene testing, there's a lot of different tests. I'm going to turn over to Dr. Reichman now. You talked a lot about the goals of using radiation for patients with stage 4 lung cancer, hopefully helping them feel better, maybe giving them more time on the treatment that they're on. One of the questions I want to ask you about is, let's say a patient got radiation and maybe a few months down the road, there's a spot that pops up again nearby, or it involves that site again. Can we use radiation again? Talk a little bit about re-irradiation.
Yeah, so gosh, re-irradiation is such a difficult concept and situation. We're really making strides in terms of prioritizing safety here, and it's a highly complex decision-making process. Actually worked with Joe Chang from MD Anderson on a website called cancerretreatment.org because everyone deserves a second chance. It's free to use for radiation oncologists, and it helps us navigate through these decisions. But in reality, there's a lot of hand waving involved in these situations. And for me, the most difficult thing is how to counsel the patient in the face of uncertainty. And so, sure, by the books, I could come up with a plan anywhere in the body, to feel okay and really treat myself to feel more comfortable. But I tend to over counsel patients on the risks in these scenarios. Often it can be quite safe, but it really depends. Like, it's hard for me to discuss specific scenarios because it's so complex. But there's been plenty of times where I've done radiosurgery in the lung, or SBRT or SABR would be the appropriate term there. And then there's been a spot that's popped up a centimeter or two away. And as long as that's like in the middle of the lung, folks tend to tolerate that pretty well. But the difficult scenario, where and they don't even realize that they're getting a second course often with stereotactic radiation in the same area or SBRT. But when things become like close to the chest wall, there can be a higher degree of chest pain. Often we can do temporary rib blocks with alcohol, and sometimes permanent rib blocks to help with that chest pain. But then the central areas around the windpipe and the heart, it becomes more complicated. And so it really is driven by where is the spot and what's the scenario? What dose are we giving? Is it a higher dose or a lower dose? How is that patient doing? Are they going to want to do a more aggressive treatment or a less aggressive treatment? So the short answer is I struggle with that on a case by case basis, and it really depends on the patient.
And is there a hard cutoff in terms of timing from the last time they received radiation?
These are really good questions. Yeah, generally speaking, we feel better when it's been 6 months. I mean, I like 2 years. But we can justify treating within 6 months if it's out of field. If it's in field less than 6 months, then I think it's kind of silly. The definition of insanity is doing the same thing and expecting different results.
Mm,
But, with a good dose, the first time around, 95% of the time, you're not dealing with recurrences, right? But if it was a gentle dose to begin with, then it might make sense to treat within the 6 month window. So
yeah.
it's complicated. Yeah.
No, thanks for sharing that. It's very nuanced. I'll ask you one more question because I bet we're going to get this question from the audience. Keep your questions coming at the end. I kind of preface that we're going to talk about this a little bit, so I'm going to go ahead and go into it. Photons versus protons in non-small cell lung cancer. What do we
Totally.
do? How do you decide? Talk us through it.
Yeah, yeah. So, I mean, here's the thing. I had a graduate research assistantship at Georgia Tech for medical physics, and I did my research in proton therapy. So, designed a passively scattered nozzle, so the older school types of protons, based on the Harvard nozzle, the Gottschalk nozzle. There's a 100-page input deck of calculating secondary neutron dose. Really nerdy stuff. I say radiation oncology is the perfect blend of nerd skills and empathy. But I walked away a little bit disheartened because I really wasn't convinced that it was applicable in all scenarios. However, on paper, they look fantastic. And
Mm.
so it really depends on the patient. And also, I think the main advantage is affecting less of the white blood cells, especially in the immunotherapy era. So when we have bigger lengths of fields that we're treating, especially in curative settings, where maybe the tumor is more, involving more the lungs, such as around lymph nodes around the heart and like a lower lobe tumor, that means you're treating a lot of the lung from top to bottom. In those scenarios, the advantages of protons is they stop in the tissue and you're exposing less of the circulating blood to radiation. So if there's niche scenarios where I think it benefits, and we call that lymphopenia, right? And so that's lower white blood cell counts. We kind of don't want to knock out the white blood cells, especially in the immunotherapy era. So I do think there are niche uses. Perhaps in the metastatic setting, though, maybe not as much for non-small cell lung cancer. Actually, the data that we have might suggest increased or less safety, more pneumonitis with protons. However, that's old school protons, not the new school protons. In 2010, there was only 13 proton therapy centers in the United States. Now I think there's over 50, and there's
Wow.
more advanced proton technology. And also the sunk costs are a lot less. So two-thirds of Americans don't have access to protons. So I think access is a huge thing, but photons have also come a long way. And so I think access is key. There are some advantages, but in reality, at Ohio State, for example, I'm sending my young adults over there with Hodgkin's lymphoma, and the wait list is 3 to 4 months. So
Wow.
you have to think of the advertising too. They used to cost $250 million to build. Wow, right? So we have to recoup those costs, but now they're 30 to 50 million dollars. I think in 10 years, that might come down to the single digit millions, and then we'll have more access. So it's a complicated thing. And modern photons are fantastic. And the numbers I was quoting for safety and efficacy were with photons. So sorry, I couldn't give a concise answer there. It's a really complex topic. And MD Anderson, a lot of the work they're doing there, Stephen Frank, for example, that randomized controlled trial for esophageal cancer was recently published. So there's a lot of fantastic work happening, but it's complicated.
Yeah, thanks, Dr. Reichman. I asked you two really tough questions. I'll go back to you, Dr. Abu-Ruz. When is the right time for a patient and their family to ask about ADCs? How are you sequencing it? Talk us through the timeline of when access and being on ADC is the right time for a patient.
So right now, if you think about the approved ADCs in lung cancer, they're approved in advanced lines. So we have Dato-DXd, we have T-DXd, and then we also have Teliso-V. The three of them are approved in advanced lines. I would say that the right time to ask is probably right at the beginning to know, to kind of build like a roadmap of the treatment options that we have in case the cancer continues to grow on one treatment or another. And this way will help the clinician and the patient also, plan for the future a little bit ahead of time. So the right time to ask is always, at the beginning or whenever a progression happens. But just keep in mind that the approved treatments right now are in the advanced lines. So after progression on chemotherapy or chemo plus immunotherapy, or in some cases, targeted therapy.
Yeah, thanks for answering that. And I'll echo what you said. I think the right time is now, always at the beginning as well, too, because clinical trials, right? We're trying to
Yes.
think about moving these drugs into the front line, into patients newly diagnosed, untreated. And you won't know unless you ask. So I think that's
Yeah.
important.
Yeah, I think one thing also to mention, you mentioned that, Eric, is clinical trials. There are a lot of ADCs in clinical trials. So that's why the right time to ask is always at the beginning, because there might be a clinical trial for an ADC that makes sense to be used in the first line, right? In certain scenarios, not in all scenarios. So always ask about ADCs, about clinical trials, and keep in mind that the approved ones are in advanced lines.
Perfect. All right. Now I've got two questions in the last 5 minutes where it overlaps for both of you. Okay. So, one of the things I worry about a lot with ADCs, with radiation, is an overlapping toxicity, pneumonitis, right? Inflammation of the lung. Talk us through, from both of your perspectives, sort of the risk and management of pneumonitis based on your specific modality of treatment, the systemic option. Either you can start first.
I can go first. So yes, that's a big issue for ADCs. And as I just mentioned, most of the ADCs are approved in advanced lines, right? So most of these patients would have had received immunotherapy in the prior line. Immunotherapy by itself can cause pneumonitis. So for my end, as a medical oncologist using drugs, if I have a patient who had developed pneumonitis on immunotherapy, I would be very cautious in using something like TDXD, let's say afterwards, or maybe like day two afterwards, because both of them can cause pneumonitis. We know how to manage these pneumonitis. I work a lot with our ILD specialists in such cases. There are a lot of tricks that you can use in order to reduce the risk of pneumonitis or manage the pneumonitis if you truly feel that the patient can benefit from that particular drug. But always keep that in mind. There's overlapping toxicity between all the modalities that we use, whether it was radiation or immunotherapy or targeted therapy, and sometimes the combination itself. There are trials for, an ADC plus targeted therapy. This combination can lead to pneumonitis, not in all patients, but in some patients. So we have to keep that in mind. Some patients are more susceptible to pneumonitis due to their comorbidities, such as COPD or having some damaged lungs or, any other things that can lead to maybe like autoimmune diseases. So we have to keep all of these things in mind when we're choosing our ADCs.
Yeah, Dr. Reckman.
Yeah, this is I really struggle on a case by case basis, especially in the modern like antibody drug conjugate era. I have seen reactions, even though I'm treating per guidelines, in breast cancer, for example, concurrent immunotherapy with radiation. There's a less than 1% chance of pneumonitis with treatment for breast cancer. And then, I've seen examples of folks whose breathing is affected, and I've pressed underneath the ribs, and there's tenderness in the lungs when I press on the ribs, like not in the rib itself, but from the inflammation of the lining of the lung. So it's disproportionate to what I ever see with just radiation alone. But per guidelines for breast cancer, you can give it concurrently because the trial did it that way, right? So there's a lot of coherent and defensible ways to practice and whether or not to do things concurrently or break from systemic therapy. And then, for example, not antibody drug conjugates specifically, but EGFR inhibitors, when those are stopped, there's something called a flare phenomenon where kind of the disease can flare up. And even though it was controlled, you can kind of lose control even when people are off those medicines for a week or two. So I really struggle with this on a case by case basis. And as radiation oncologists, especially in the community setting, have to be aware because a lot of times I'm the one making the call, whether or not to stop. My medical oncologist is very well informed. He is amazing to work with, but it's so hard to keep on top of all the new data. And a lot of times when these drugs are investigated, radiation is not allowed on those trials,
Right.
right? And so we don't have that prospective data to help make these decisions. So that's why, like I mentioned, I'm working on an app to help make these decisions easier based on how the drug works or mechanism of action and the biological half-life. But in reality, we're doing like our best guess, of how long to stay off medicines because a lot of these medicines are known to improve survival. And I kind of worry about flare phenomenon outside of folks who might have targetable mutations for lung cancer. So, yeah, in brief, I struggle with this on a case by case basis. And it's the decision that is made by your local oncology team. And often they're not really easy decisions to make.
So, is there a perfect washout period that you recommend for each of these cases?
So, generally speaking, I like two half-lives, but often that's not feasible. For example, in small cell lung cancer, which isn't the topic of today, tarlatamab, that has I think it has a 7-day biological half-life. But then, you have to do the building taper up dose. And so
Yeah.
I have to give radiation quickly, and I allow 1 week bookends, which is one half-life. But ideally, when we're worried about toxicity, I like at least two half-lives. But feasibly, we don't have that time to do it. So
Okay.
it impacts my recommendation of number of treatments as well. I'm curious of your biases as well on this.
So if I use the example of, the number circulating between medical oncologists is like 6 weeks. Why exactly? I I don't know. I mean, as far as I know, there is no real data. But sometimes we see these like second opinions or consults where the patient had already started chemo and immunotherapy, and then it turned out the patient has a targeted alteration that you can use a drug for, targeted therapy for in the first line. So I stop immunotherapy. I allow maybe like 6 weeks, maybe like 2 cycles of chemotherapy until I start the immunotherapy to prevent or to try to reduce the risk of the overlapping immune toxicity, mainly pneumonitis. So, in our world, it's 6 weeks, but it's a case by case situation.
Yeah, and I'd just like to add to immunotherapy just real quick. I'm
Yeah.
fine with single agent immunotherapy as long as it's not CTLA-4, and it depends on the dose. But dual agent immunotherapy, I get a little bit of cold feet depending on the scenario. But single agent, I'm usually fine to do concurrently. And then one other thing I think of, as long as I can wait, because the average time to response on immunotherapy alone, so that's what we're talking about now, just immunotherapy alone. But the average time to response, generally speaking, is 2 to 3 months. So if I feel comfortable to wait, like if it's not right around the windpipe and I'm worried about, maybe trying to keep the lungs open with radiation, I like to wait 3 months because the average time to response on immunotherapy alone is typically 2 to 3 months. And that's also the average time to toxicity. So if I know that those patients are going to tolerate immunotherapy well, I don't like to do both at the same time to begin with sometimes. So we know like who done it if people, have a side
Okay.
effect. But yeah, I just wanted to touch on that since we were mentioning immunotherapy as well. I hope that wasn't too complicated though. These are such complicated topics. They really are.
Yeah, no, thank you both for really unpacking these gray zones in thoracic oncology, to be honest, right? Not every patient case nicely, neatly fits into the algorithms that we have, right? There's a lot of nuances that go into this. So thank you both. Don't worry, guys, they're going to be rejoining us for the final panel. Keep your questions coming. But I really want to thank you both for kicking off this program very strongly. So thank you. Next up, I'm really excited to introduce a dear friend and colleague of mine at MD Anderson. I'm pulling up her bio now, guys. It will take me the entire session to go through her entire bio. I'm convinced Dr. Mara Antonov does not sleep. She is an associate professor of thoracic and cardiovascular surgery and the program director for education at MD Anderson for the fellowship program. She's also the deputy head of education for surgery. She holds several leadership roles nationwide, internationally. And she's an incredible human, and she is the co-partner and founder of our young onset lung cancer program at MD Anderson. So, with that, Dr. Antonov, I welcome you to the stage to talk about the role of surgery for patients with stage 4 disease.
Sorry, hopefully you can hear me now. Thank you so much. I really appreciate the opportunity to be here with you all. I know there will be some redundancy of what's already been discussed and what I'm going to talk about, but within the realm of talking about studies in oligometastatic lung cancer, current data and definitions, I'm hoping to give a bit of an overview of kind of how we got where we are right now, and then really where surgery fits into that space. So, what does oligometastatic lung cancer mean? I think to make that very clear from the beginning is going to be important to our shared understanding here. So, we know that cancer has spread beyond the lung, but when we say oligometastatic, we mean that it has only spread to a limited number of spots. And you can see variable number definitions in terms of numbers ranging anywhere from 1 to 3 or even up to 5. But I would say the most widely accepted definition is when it has spread to anywhere up to 3 spots. And that's the number that we use for a lot of our studies. And so in general, when we see other studies or other treatment patterns that may include up to 5 or 6 spots, it doesn't mean that the aggressive treatment in those situations may not be valuable, but we don't typically consider that oligometastatic. The point here is that we think it may be a distinct spectrum of advanced cancer where aggressive treatment of visible disease may actually be of particular benefit. And that's why we talk about it a lot in this space. As we clinicians and scientists think about oligometastatic lung cancer, we recognize that this may have potential for more aggressive local therapy. And I'll talk a little bit more about what local therapy means in a moment. But we think of this oligometastatic state as one that is metastatic but has limited disease burden. And the tumor biology in this circumstance may be distinct or different than what we would see from individuals who may have many greater sites of metastasis. So what does local treatment look like in these circumstances? We'll often hear the abbreviation LCT, which stands for local consolidative therapy. And local treatment means treating those cancer spots directly, not just with a drug that travels through the veins and hits every cell in the body, but specifically treating those spots where the cancer is. And the options may include a variety of different strategies: radiation, which may be in the form of SBRT to the lung tumor or spots within the bones or adrenal gland, anywhere else. You might have heard of CyberKnife to brain metastases, surgery to any of these spots, but particularly to the lung tumor itself. Or what we're seeing more often is a combination of these different strategies to try to comprehensively treat all the different spots all at once. And I do want to be clear that this is often used along with medications that may be given through the vein or by mouth, but not instead of those medications. And so you'll hear us often talk about the landmark oligometastatic trial. And I think about this study a lot. This is a study that really changed how we think about local treatment in limited metastatic cases. That's why we call it the landmark study. But this was one that's now almost 10 years old. And I think the important take-home points from this study were that it really helped us realize that by treating aggressively the local spots of disease, in addition to drug therapy for patients who have limited metastatic burden, that we can see improved time without progression, which you see on the graph on the left, as well as increased time until new spots develop, which you see in the figure on the right. So this is really important, and it changed the way that we think about local therapy for patients who have stage 4 lung cancer. We also saw with that study that came out again almost 10 years ago that individuals who had comprehensive local therapy, so this is providing local therapy to all sites of disease that are present at the time that one is diagnosed, that individuals who had that type of really comprehensive local therapy had improved time until progression, increased time until new metastases, and even improved overall survival. One of the questions we get a lot is, who are the right patients? So which subgroups of patients are most likely to do the best with local therapy? And for me as a surgeon, I think about who's going to do the best with surgery. So who benefits from this type of local therapy? We did a review of almost 200 patients at our hospital who had this type of local therapy with surgery or with radiation, and compared those who had comprehensive treatment of all sites present at the time of diagnosis to those who didn't. And so ultimately we came up with a group over 18 years of almost 200 patients. And I do want to be very clear when I show you the results from this group that the years were 2000 to 2017, and very few of those patients at that time had what we know as oncogene-driven disease or molecular profiling that would allow them to get special treatments for mutations like EGFR or ALK or ROS1, other different types of mutations that we can treat at this point in time. So with that group of patients, we saw that by giving comprehensive local therapy to this large group of patients over a period of over 18 years, in an era when our drugs weren't even that good, we still saw improved survival for patients who had local aggressive treatment to all sites of disease that were present at the time of diagnosis. The next thing we did was try to figure out who would have better overall survival with that type of aggressive, comprehensive approach. And in this study, we showed some things that I think may be quoted, may be knowledgeable to other individuals, but I want to point out that they don't necessarily apply to everyone. So in this study, we found that individuals who maybe didn't have as large of tumors, as much involvement of lymph nodes, patients who didn't have bone metastases, tended to do even better with this comprehensive local therapy. But I want to point out this was more of a historic group of patients who, number one, were older than many of the advanced cancer patients that we see today. And number two, very, very few of them, to our knowledge at the time of their treatment, had targetable alterations that we could treat with a targeted therapy. And so we've actually found since that time with other studies that in patients, for example, who have EGFR mutations and are on targeted therapy, even with bone metastasis, operating with surgery to all sites of to the lung cancer itself within the lung, and then having comprehensive therapy to the other sites of disease, typically with radiation, is beneficial. And I think that's really important to acknowledge for any patient, for any caregiver, and for their care team, that when we look at studies that exist in any patient population, you really have to be sure that it applies to that individual. So if we have a study that maybe shows that surgery or radiation isn't particularly helpful in certain groups of patients with stage 4 disease, you have to look at who was in that study, because we typically tend to see the best outcomes for that type of approach for individuals who do have some sort of oncogene-driven disease. And so I don't say that just to speak about people who can receive targeted therapies, but mostly to acknowledge that we recognize that there are large groups of patients, caregivers, advocates who are looking at these scientific studies, as well as practitioners who are trying to apply these data to the day-to-day treatment of patients. And if the patients who are in the study don't share the same treatment characteristics, the same health status, the same additional medical problems as the person for whose care we're trying to come up with the best plan, we have to acknowledge that the data have to apply to the individual. So I know that's a bit of a side point, but I think it's really important because our data in this space are quite limited and they may not apply to everyone. Sometimes we have to think outside the box. So what about lung surgery itself? In that same group of patients, again, not quite as many of them had oncogene-driven disease. We just tried to see the benefit of surgery and whether it could be helpful for these patients. I'm going to show a figure on the next slide, and this is my my preface, my warning. Please don't take a screenshot and take this out of context. There are two survival curves that are superimposed on the same figure, but they are not equal groups of patients. And I hope that this is at least a little bit of a lesson on how we can interpret data in studies and how it applies to real life and to real patients. So here you see that we looked in our experience at patients who had a surgery or radiation across that 18-year period with oligometastatic disease. And the treatment was relatively safe in both groups. And over a period of follow-up of almost 5 years, the median overall survival after surgery in this group of patients was 55 months. The median overall survival after radiation in this group of patients was 23.4 months. It's super important that we don't try to act as though those two groups of patients were the same. And so that does not mean that any given patient would do better with surgery or with radiation. It does reflect the reality that we selected the healthiest, strongest patients with what we already thought were pretty good prognoses to have surgery. That doesn't mean that surgery is better or equal or worse. It means that we haven't compared it. This is not an appropriate comparison, and so you can't say one is better than the other in this specific study. But what you can say is that both of these strategies showed median survival time that was much better than what we had seen in patients who weren't getting any type of local therapy. And so both are reasonable treatments to include in clinical trials and patient care going forward. So how much lung should be removed if we do operations for this? This is something we surgeons debate a lot, and people may have heard of operations like a lobectomy or a pneumonectomy, wedge resection. And there is really an abundance of data, lots of clinical trials where we discuss and debate over and over how much lung we should remove for early stage lung cancer, for stage 1. Stage 2 and stage 3, it's pretty well accepted that we will typically take out an entire lobe or more if we need to, but we don't go less than a lobe. But interestingly, we found that for patients who already have stage 4 disease, taking out less than a lobe is actually the same as taking out a lobe as far as we can tell, as long as we get all of the tumor out. Because ultimately, when you take out an entire lobe, even if that's more than what might be needed for early stage disease, the goal is to keep it from spreading elsewhere. Once it's already spread elsewhere, it may not be of benefit to take out an excessive amount of lung. And this is something that we were able to show again with a larger group of patients using some international patients as well. So how should we handle the lymph nodes? In general, most surgeons, if they're doing a good operation, are going to take out a lot of lymph nodes to be able to see the structures in order to get thorough information from the slides from the pathologist. But how many do we really need to take out? We do know that in early stage disease, in stage 1, it matters how many nodes you take out in terms of the patient's survival. But we've actually found that in stage 4 disease, taking out as many as possible to provide good prognostic information, to get information to our pathologists and our colleagues in medical oncology is helpful in making treatment decisions, but it doesn't directly change survival. So ultimately in these operations, the number of lymph nodes taken out, we don't know that there's a right answer, but probably the right answer is to take out as many as you can as long as it's safe and not to do anything that is too dangerous or heroic because it may not change the outcome. In terms of looking at long-time outcomes of using surgery for local therapy in these types of cases, we have some pretty good data. And what I want to point out when you look at this slide is this is how we're used to looking at the proportion of patients surviving or the proportion of patients without progression. We have progression-free survival here in the red colors and overall survival in the blue. And the numbers that you see at the bottom across the time are in months. This is how we normally think about patients with stage 4 lung cancer. We've got 0, 12, 24. This is how we often think about it. And a lot of our figures going back a couple decades, we never really got much higher than about 12 or 18 months. Well, as much as I love this figure and seeing how well patients are doing with local therapy, I like it even better like this when we show it in years. And that's an exciting change to be looking at patients with stage 4 lung cancer getting local therapy and seeing these progression-free and overall survival numbers that are up in years. Because that's what we want, is prolonged, meaningful lives for the patients for whom we care. And, we've had an opportunity to combine some of our results with those from colleagues across the globe. And ultimately, when we look at these bigger data sets, we get more patients that we can put together. And we're really seeing these phenomenal longer term outcomes from offering surgery as part of stage 4 disease. And so this is what we're looking at is, median overall survival extending out 78 months, median progression-free survival more than 3 years. So that's very exciting. So beyond the survival, why do we operate? The rationale for local therapy, whether it's surgery or radiation, is theoretically to get rid of the primary source of new metastases, to decrease the number of tumor cells that can develop mechanisms of resistance, to debulk so there's lesser disease burden for effective drugs, and to maybe convert what was once a lethal disease to a chronic disease, even if it's no evidence of disease. Some practical reasons for surgery itself is that we can obtain tissue for looking at pathologic response. So what can we see under the microscope? What can we do with mutational analysis? We actually just saw a study at the North American Congress on Lung Cancer in Chicago last weekend, where the group from UC Irvine showed some data demonstrating that a very small series of, I think, 6 patients. For all 6 of those patients, the information they got looking at under the microscope showed that they changed the systemic therapy, the drug therapy for the patients based on having that information looked at under a microscope. So that's all super important. It allows us to address any residual cells that might theoretically be left after radiation, because we don't always know when we look at imaging after radiation or after drug therapy if those cells are alive. We don't know until we take something out and look at it under a microscope. For some patients, quality of life is better with surgery. For some patients, it won't be. And that's a big part of understanding an individual's health, psychological, social situation, and really making sure we tailor every patient's treatment to that individual specifically. And for some people, it's just that closure of answering unknowns, which if it's a reasonable safety profile, reasonable risk, that can be a good reason in and of itself. So what does this mean for you as a patient? There's no single right treatment for everyone. Treatment plans should consider the number and location of the cancer spots, the response to medications, your overall health, and as well as your goals and preferences. And it needs to be guided by a multidisciplinary team. So when we think about where these things all fit together, for local therapy in stage 4 disease, again, we're trying to minimize the number of tumor cells that can develop resistance. We're trying to prolong the efficacy of a drug as long as possible. When we look specifically at surgery, we can get all this additional information by looking at under a microscope. And when we look at oligometastatic disease, again, so patients with really just a few number of spots, the goal is really to get rid of all disease possible, because we often are able to do so. So we need to understand that polymetastatic is not the same thing as oligometastatic. But I will get into that a little bit with my last couple of minutes here. So if we are going to operate, who should have surgery and what's the best way to do it? We do have some guidelines that we published in 2025 through the Society of Thoracic Surgeons. And this is a busy table that goes through the guideline recommendations, but I want to provide you with a quick summary of what these guidelines are, which is that the data provided strong recommendations to consider lung surgery as part of local therapy in oligometastatic disease, and that all patients with oligometastatic disease should have multidisciplinary evaluation. There were moderate recommendations for lung surgery in some people who have more than 3 sites and some people who are progressing in a small number of spots. But there is not adequate evidence right now to tell us how much lung we should remove, how many lymph nodes we should remove, or really whether it's better to do it minimally invasively or a little bit more invasively. Really, those things should be left at the safety discretion of the surgical team. The most important take-home point, though, from these guidelines is that all patients with oligometastatic lung cancer should undergo multidisciplinary evaluation, including surgical consultation, even if that means that the surgeon explains to the individual why they might not be a surgical candidate. I personally believe that every patient deserves that opportunity to have that discussion and to understand what the nuances are about their specific case and why certain treatments might or might not apply to him or her. So we've talked a little bit about surgery and oligometastatic disease, and this is a figure that I really like very much because we often think about innovation being led by the kind of most straightforward, and then we apply it to a broader spectrum of situations. And so, oligometastatic lung cancer is something that we've now been operating on for a bit, and it's being done in a lot of places. But what about people who have polymetastatic disease? 10, 12, 20 spots. What about people who are progressing on therapy? I certainly think that within the realm of stage 4 disease, oligometastatic lung cancer led the way, gave us the most evidence, but it may be creating a pathway for other types of patients. So just a quick discussion of some of the more recent and ongoing trials that may kind of push the limits in that situation. The LU002 study was a study of patients with stage 4 who had a limited number of metastatic sites, but greater than some of the studies I just mentioned. These are individuals who had cancer that had not progressed, and for most of these patients, the treatment was immunotherapy. So targeted therapies were not the main treatment for these patients. And what the study showed was that adding radiation did not improve survival. And so a lot of people thought of this as a negative study, but what it means is that local treatment may not benefit every patient, and that careful selection of patients is really important, and that we need to keep thinking about the types of drugs, which patients, and the type of local therapy because they all matter, and that way is why we maybe see different results from different studies. The CURB trial is another pretty important trial that I want to mention, and this was patients with metastatic lung cancer as well as breast cancer, where it was growing in only a few spots while on treatment. So this is called oligoprogression. And what this showed was that radiation therapy delayed cancer progression, and the benefit was mainly driven by lung cancer patients, not the breast cancer patients in the study. So treating a few growing spots may help disease control, even when the cancer is otherwise responding to therapy. I think that's important. I want to mention the North Star trial. This was a study that involved 122 patients. It was presented by Yasser Elamin at ESMO in Berlin earlier this year. And this was patients who were receiving osimertinib for EGFR mutated disease and either stayed on the osimertinib alone or had local therapy consisting of surgery or radiation. And what I want to point out here that's really, really important is that the majority of these patients actually were not oligometastatic. The majority of these patients had a lot more than 3 sites of disease at the time that they were enrolled. Many of them got radiation, but a substantial number of them also got surgery. And we saw what was presented earlier this year, that there was a dramatic improvement in progression-free survival for those who did have the local therapy, with a median progression-free survival that was a number of months longer than those who did not have it. And we saw this benefit was true regardless of which type of mutation and regardless of how many metastases they had. 21 patients in this group had lung surgery, and I think it's important here to again notice that most of these patients had polymetastatic disease. So the reports on those outcomes are coming soon. I hope that we'll be presenting them at a big meeting in January of 2026. There are a couple of other big trials that I want to quickly mention. The Lone Star trial closed enrollment at over 300 patients, and there are some patients who remain active on trial, and we hope to have analyses coming in 2026. This is a similar study to North Star, but these are patients who got immunotherapy because they did not have targetable mutations. Bright Star was a trial that was a feasibility study looking at patients receiving targeted therapy for ALK mutations, but again, more use of local therapy in patients with polymetastatic disease. These trials are all exciting. The number of individuals who've been impacted is small, and not everyone qualifies. We have a lot of unresolved questions. I have a lot of questions that remain in surgery, things we don't have data for. So we do have a registry trial at MD Anderson where we're looking at survival with a lot of these objectives, trying to figure out how much lung we should take out, how many lymph nodes we should take out, timing, and how we combine this with radiation. Ultimately, I think the issue here is that we need more data. We need to consider offering surgery to more patients with oligometastatic disease, but also those who are progressing in just a few spots, those who have more than just a few spots, and we have to track the outcomes. We definitely need to collaborate. We need to think at the opportunities to put together our efforts with those of all specialties and to collaboratively work with patients and caregivers. And so my key take-home messages for patients in discussion of all of these elements are that oligometastatic lung cancer really means cancer has spread, but only to a small number of spots, and that some patients may benefit from treating all visible cancer, often using radiation and sometimes from surgery. The clinical trials do show that local treatment doesn't help everyone, so picking the right patient matters, and treatment choice needs to consider overall health, the response to the drugs, and the goals of that patient. I do believe very strongly that every patient with oligometastatic lung cancer should be reviewed by a multidisciplinary team, including an experienced thoracic surgeon, and ultimately asking about clinical trials is super important. So I thank you very much for the opportunity to chat with you all. I know this was a brief I guess, tornado. But I'm happy to be able to talk about all of these things that are so important to me. And I thank you, Dr. Singhi, and the whole team for giving me the chance to be here.
Thank you so much for the tornado, tour de force presentation there. Really, really enjoyed it and really appreciate your advocacy and expertise in this space. All right, last but not least, I am excited to introduce Dr. Meera Patel. She's also a dear friend. I feel like I've been saying that every morning. It's very true. Honestly, the lung cancer community, you guys can realize, is very small and close-knit, and we all work very closely together. But Dr. Meera Patel is an assistant professor of medicine at Baylor College of Medicine, just down the street here in Houston. She's actually the lead of their thoracic medical oncology program at the Cancer Center, and she has a particular focus in advancing treatment options for patients with mesothelioma and immunotherapy. She's going to be talking to us today. We're going to be taking a big step back about biomarkers, right? So biomarkers, how do we personalize treatment for our patients with non-small cell lung cancer? So with that, I will hand the stage to you.
All right. So, thank you guys for having me. I'm really excited to be here and kind of share some information about biomarkers because I think it's been a really important topic that a lot of people have been talking about, and it's really helpful to go back to seeing exactly what these biomarkers are that are needed for some of these exciting and novel therapies that we have. All right, so disclosures, I'm on an advisory board, but has nothing to do with what we're going to be talking about today. So we're going to talk about biomarkers, the what, when, why, and hows of biomarkers. What's been approved right now? What are the emerging and more exciting biomarkers that are yet to come, as well as questions to ask your provider. And then when and why should we ever consider repeating our biomarker testing if we've already had it done? So looking at a biomarker, I want you to think about a biomarker as like a little sign in your body that gives your doctors information about your cancer. It's like a fingerprint of your cancer or maybe an ID card that your cancer cells are carrying that says, hey, this is what you need to know about me. And when we think about that fingerprint, that helps us kind of understand what's driving the growth of your cancer. What treatments might be something that we need to consider for you particularly? And, it can also tell us which treatments are probably not a good idea for you based on what we know. And it might even give us a little bit of an information about how aggressive your cancer might behave or how likely you are to have a response to what we would call standard of care therapy. Now, when we talk about biomarkers, biomarkers can be a wide range of things. The normal conversation usually surrounds the genetic mutations, right? Which is going to be a misspelling in your DNA that occurs at some point in time that led to the growth of the cancer. But a lot of times it can also be expression of proteins or molecules that can be found either in your tumor or in your blood. And that's how we can test these things. So why does this matter? We've come so far in medicine and we're at a point now where, treatment is no longer a one size fits all, right? Back in the day, 20 plus years ago, all patients would get chemotherapy, maybe get surgery depending on, if it was localized, get some radiation, but it wasn't very much tailored specifically to each individual. And we live in a new day and age where we have the possibilities with our technologies to make these changes and make sure that we are giving patients what they deserve. So matching you to a targeted therapy and a treatment can make a big deal because it can help go after your specific cancer cells. And it can identify whether or not maybe immunotherapy is going to work better or worse for you. It can tell us which treatments to avoid, and it gives us a clearer picture of potentially your prognosis. We know that certain mutations may harbor a worse prognosis in certain patients than others. And it can also help us identify clinical trials that you might qualify for, where we have the ability to get new novel treatments that might be better than the standard of care. And so biomarkers are helping us personalize your care to make sure that you get the right treatment at the right time. And how do we test these biomarkers, right? There's very tedious scientific things that get done in a lab. But the two main things I want you to take away from here is we can check biomarkers specifically on a tumor biopsy, a piece of tissue that was taken to diagnose your cancer that's sitting in somebody's lab. And that can be sent out to a company or be tested in-house depending on where they can do it at your specific oncology practice's location, where they look at these genetic changes, they look for the proteins, they look for all of the markers, and the tumor biopsy gives us the most detailed information. We can get the most information from the tissue. However, we also know that sometimes tissue is not adequate enough to send these tests for. And so we can also use a blood draw. When we use a blood draw, you get your blood drawn and they're able to isolate or take out the tumor DNA that might be circulating in your blood and send that out for testing to look for, again, these biomarkers. Now, a lot of times we use the liquid biopsy or the blood test in situations where we need a quick answer, right? We know that it takes a little bit longer to get information back from the actual tissue. It takes somewhere between 2 to 3 weeks, and it varies from different institutes. But we hope that the blood test comes back closer to 7 to 10 days, and we may have more information quicker. And so we like to use it for that reason. But also sometimes if, doing a biopsy is not feasible for one reason or another, we can also sometimes lean on this liquid biopsy. However, most patients get both their tumor biopsy as well as their liquid biopsy sent for what we would call next generation sequencing to look for these biomarkers. Now, when we think about biomarkers, 20 years ago, we didn't have very many biomarkers. And in the past 20 years, we've had significant advances in being able to find each and every one of these biomarkers. EGFR is our age-old biomarker where we have learned so much in how we can be of assistance to these patients because they weren't really responding to the traditional treatments, and it wasn't really well understood until we were able to target that specific mutation. And since then, we've had several different approvals, and these are all of the drugs that we have, all of the targetable biomarkers that we have, drugs that are approved for that we can use to treat patients' cancers. Now, keeping in mind that the majority of all of these targetable mutations have approvals for drugs to be used in the more locally advanced lines of treatment. And so that means that patients are generally in a stage 3 or stage 4 setting when they can get most of these medications. However, as our research has been advancing, we're trying to move some of these medications up in the lines of therapy. And so EGFR and ALK have been two of our mutations that have been able to be moved up into the adjuvant setting where patients would get treatment potentially after their surgery or chemoradiation. And so another area of the biomarkers is the immune-related biomarkers, right? So the targetable mutations are, your ID card that has a little flag on the cancer cell that says, here's my mutation, come and get me. But the immune-related biomarkers are your PD-L1, your tumor mutational burden, and potentially your microsatellite instability. And we're going to talk about those a little bit further in a couple of slides, okay? So this is what we already know, but there's so much more coming. Right. So with all of the technology that we have, we know that there is potentially ways of testing the blood to find out how much cancer cells may still be around after you've maybe gone through a surgery with Dr. Antonoff and had, all of your cancer removed. Could there be still some microscopic cancer cells that might have been left behind? And this is that minimal residual disease concept that, they've been looking into and they've been testing. And, it hasn't become something that is definitely FDA approved, but I think it's something that we're going to have to look out for because I think it is going to hopefully be something that's helpful to our patients in the future. We also have circulating tumor DNA where we again do a blood draw and look for tumor DNA that might be able to help us predict, is this patient going to have an early recurrence of their cancer? There's several different targets and new emerging biomarkers that are there. There are things that we've already found from KRAS, but there's new KRAS mutations that we're looking at, newer variants of EGFR and HER2. But then there's other things that we haven't been able to target that are all in clinical trial, looking at TP53, MTAP deletion, SMARCA4, FGR FGFR, sorry, Nectin-4, integrin B6, and the folate receptor alpha, and many more. I mean, there's just so many for us to be able to put onto one slide. It's kind of difficult. But then there's also technologies that are looking at, gene expression signatures to say that is there a specific thing that we can find out from the way that this gene is expressing proteins to help us understand, is it more likely to come back? Is it more likely to move on to other organs? What does that mean? We've also been looking at the microbiome markers. So all of us have normal gut bacteria, and they're looking at this gut bacteria, and does it show us why some people may be responding to immunotherapy better, and does it affect our responses to immunotherapy? They're looking at genetic variations in patients, like their HLA type, and their immune fitness, to say that if you have a specific HLA type, are you more likely to respond to an immunotherapy? And then, we can't forget about AI. It's been, front and center for most of us, and we've been hearing so much about it. But they're also looking at AI-based response predictors. Can we use a lot of our data, whether it be clinical and our biomarkers, and putting everything together and use that to help us determine, are patients more likely going to respond to one therapy versus another? So, when is the right time to test for biomarkers? And I think that's a very key and important thing, because at the time of diagnosis, before we start treatment, is probably one of the most important moments for us to check for a biomarker, because this is going to help make sure that we choose the correct treatment option at the beginning. Now, if at some point, unfortunately, our treatments stop working, because we know that that can happen and our cancer can outsmart our medications, and we do have progression of our cancer, which means that the cancer either grows or it returns. The cancer can change over time, and repeating the biomarker testing at that moment may be helpful, because it might give us other new options that we didn't know were options previously. And then after surgery for certain types of cancers, it may be important to check biomarkers as well. Now, after surgery for certain types of cancers, it's not always standard of care, but it can be done also through clinical trials. And this can help us potentially guide whether a patient needs extra treatment or adjuvantly after their surgery. So, kind of moving to the other side of the biomarkers and looking at the immune biomarkers, PD-L1. PD-L1 is a protein that you can find on your cancer cells and some of your immune cells. And I want you to think of it as a little shield or a break that is on the cancer cells, and it hides it from your immune system. Okay, so knowing what a PD-L1 level is can potentially help us when we are looking at treatment options. So how do we use a PD-L1 level, right? So PD-L1 testing helps us say, is this patient going to be able to respond to immunotherapy? And what it does is, immunotherapy, in a very simplistic way, works by releasing the immune system's brakes off of the cancer cells. So your immune system, which will naturally detect anything abnormal in your body to get rid of it, right? Like when you get sick and you get exposed to bacteria or a virus, your immune system activates and says, oh, this thing does not belong in my body. We need to activate the immune system to get rid of it. So if we use our immune system in a similar way, it can allow the immune system to recognize that cancer cell, attack it, and try to get rid of it. So PD-L1 testing can help us determine, one, is immunotherapy an option for you? And two, should immunotherapy be given alone, or should it be given in combination with chemotherapy? And so it helps us guide a lot of our treatment choices in the event that we don't find a biomarker that we can target outside of that. And so how do we test for PD-L1, right? So again, that tumor tissue sample, either from a biopsy or from your surgery, is sitting somewhere in a lab, and that can be sent out for testing or can be done locally at your lab, where the pathologist will take a stain and apply it to the tumor and look at it under the microscope to determine how many of these cells are testing positive for PD-L1. Now, how do we interpret this? So most of the time, you're going to get a result back that gives you a percentage. So, there's been some categories that have been made that, if it is, less than 1% or 0%, 1 to 49% or greater than 50%. And right here on the right-hand side, you can see the tumor tissues, and on the bottom, you see the PD-L1 staining where it was less than 1%. You don't really see much brown there. And then between the 1 to 49, you kind of start seeing some brown. But when it was greater than 50%, it was quite obvious that there was a significant amount of brown there, which was your PD-L1 that was testing positive for that protein. And so, in general, we believe that the higher the PD-L1 level, immunotherapy is more likely to help. And we believe that if it was lower or negative, it may still work, but it might need some combination with chemotherapy. The important thing to remember is PD-L1 is not the best biomarker. We're looking for more biomarkers to help us determine how immunotherapy works and how we can better gauge people's responses to it. However, it's a guide and it's not a guarantee. And I want to be very clear about that because there are going to be people that have a lower PD-L1 level that got immunotherapy that still have an amazing response in comparison to somebody who had, a different level. So why do we sometimes have to repeat that biomarker testing? Over time, sometimes our cancer can evolve. It can develop new mutations. It can develop resistance mutations where, your cancer has outsmarted those drugs. And, maybe sometimes your previous treatments over time, causes changes in the biology of your tumor. There's new therapies that become available all the time. We see new drug approvals and things that have been in clinical trials that come, to the mainstream, which is always exciting. When you first got your first test, it may not have been a complete test or it might have failed the first time because we didn't have an adequate sample. And, repeating the test helps us ensure that when it comes time to discuss treatment options, we have all of our options on the table. So when we think about what are the things that are important for us to ask our providers, right? I think, it's a really overwhelming visit when we start on the journey of our lung cancer diagnosis. I think there's a lot of information that gets thrown at us as patients, and it's hard to digest it all. And so remembering to ask about, has my cancer been tested for all the recommended biomarkers, I think is a really important first step. There are expanded, really wide panels that they test anything and everything. And then there are focused panels where they only test things for lung cancer. The benefits of, testing the wide range of things is we get a lot more information. So should there be a clinical trial that maybe there's not an FDA drug approved for, but maybe there might be something promising that might be beneficial to you, we would be able to pair you with that clinical trial if that made sense for your treatment. And so I kind of favor the wider panels if they're possible, but even at minimum, all patients should be getting that lung cancer specific panel. And was the testing done on your tissue or your blood or both? Like, how did we get these answers? And what did we find? What does this mean for my treatment? Could there be additional or more comprehensive testing that could help, like the next generation sequencing, like I was discussing about those wider panels? And should I have a liquid biopsy in addition to the tissue testing, right? I would argue that most of the medical oncologists will usually send both if they can and they have the opportunity to. If my test comes back negative, does that mean I need more testing? Like, what does negative testing mean, right? If it wasn't present and there was no mutations found, that's one thing, right? But if it was an inadequate sample or they weren't able to run the full panel, that's another thing. What did negative mean? How will biomarkers change my treatment plan? And are there clinical trials specifically for my biomarker that I could be on? If my cancer grows later, should we repeat the testing? And how long will the results take? And can treatment wait? And I think that by far is one of the most frustrating things that patients do encounter is that it does take time to get these tests back. I mentioned earlier, sometimes it can be on the order of 2 to 3 weeks. And I feel like as a patient, we get a diagnosis, we go see the oncologist, and it feels like this hurry up and wait situation. We got to hurry up and do this. And then we're just waiting and we feel like we're waiting for too long. But at the same time, it is very important to make sure that if there is a biomarker, we do find it and use it so that the right treatment is used at the right time and it is the appropriate treatment for you. So in conclusion, I think precision medicine is here and treatment is not one size fits all. And that's why biomarkers matter to us, right? It matters because we want to make sure that we are personalizing the treatment options to the patient. We should be asking our providers if they have ordered biomarkers on our tumor. And sometimes, unfortunately, we won't find anything and we won't find a biomarker that maybe we can potentially target or that is going to actually ultimately change our treatment options. But it is important to check for these biomarkers and make sure that if there is something there, we are planning to use those to our advantage. And repeat biomarker testing at progression is very much important. And with that, I thank you guys for listening. And if you have any questions, I am here to answer them.
Thanks, Dr. Patel. Really appreciate that. All right, guys. Yeah, keep putting in your questions into the chat. We're going to have a dedicated session in just a little bit where we'll bring back all the esteemed panelists to help answer those questions. Right now, I'm going to invite back Dr. Mara Antonov to join Dr. Patel, and we're going to have a little mini panel about some questions before we go into that Q&A from the patients. Dr. Antonov, I'll start with you. How do patients and their families know if surgery might be an option for them, even with stage 4 disease?
Well, great question. So I don't think any patient can independently know if they're going to be a candidate for surgery. And it really, as inconvenient as it can be for patients and their families, I think it really does require detailed evaluation by an experienced thoracic surgeon as part of a multidisciplinary team. I think the story or the situation we hear more often than not is that a patient just wants to know if they could be a candidate and they don't necessarily feel comfortable asking for that type of evaluation, or they're cared for by a provider who doesn't believe it's necessary and thinks it would be a waste of time. And so I do think it's important for us to advocate for our patients among providers that regardless of what their instinct may be, I personally feel that any patient who wants a second opinion, another opinion from any other specialty or within my same specialty really deserves it. They deserve the opportunity to have that conversation. I wish very much that we could tell patients, like, here are these three criteria, and if you meet them, you're a surgical candidate. Or even patients will reach out to us with their very extensive histories on paper. And still, the hard part about surgical decision making is that we really most often do need to meet someone in person or at least on a virtual visit, review the imaging, talk about their goals, talk about where they've been and everything that's happened. And I wish that those are things that we could pull out of, a brief note or a brief telephone conversation, but they typically aren't. I know that, real visits can be time and resource intense for patients and their families. And so every individual kind of has to think about whether that's something that they can do, if that would help turn over a stone for them or not.
Yeah, no, I appreciate that. And that's also how I think about it too. We use this term local consolidative therapy, LCT, and using local therapies that you and Dr. Reckman offer for our patients, even with stage 4 disease. And I have a rule of three when I'm talking about that concept. And you've heard me say this, it's got to be the right patient at the right time with the right team. So I think that's really the emphasis and the theme that we try to display and sort of amplify in terms of messaging. Another question for you, before I move on to Dr. Patel. How do you decide on the type of operation that's going to be recommended for a patient?
So in stage 4 disease, it's 100% based on the imaging for our preliminary plan. And then there's intraoperative decision making that takes place as well. And I point that out as contrast to earlier stage disease, where earlier stage disease, it's the imaging, it's the patient's health, it's the stage of tumor, where someone might be able to take a wedge resection or a lobe, but you choose to do the lobe because you think it's going to prevent recurrence, et cetera. But in stage 4 disease, it's a different situation. We're trying to get the existing disease out with negative margins. And so ideally, the lesser operation we can do that's going to be as thorough as possible. But I do very clearly articulate to patients that, truly with any surgical procedure, you have to have a great relationship with your surgeon and trust that intraoperative changes may take place regardless. Stage 4, stage 1, whether it's gallbladder removal, lung cancer surgery, toenail removal, doesn't really matter. You have to trust that that practitioner is going to make choices for you that are safe and really will be align with your goals in a moment when you'll be not available to make decisions for yourselves. And so we try to tell patients what types of things might occur and what types of decisions we can make up front and what types of decisions might need to be made intraoperatively. But I think really establishing that relationship, that trust, that rapport is most important.
Yeah, thanks for offering that insight. I'll move to you, Dr. Patel. We use in non-small cell lung cancer biomarker testing, and sometimes it's used as a buzzword. And I don't want it to be a buzzword. I want it to actually be something that we put into practice for our patients. And so when we're talking about biomarker testing, another word that we use alongside it is comprehensive biomarker testing. How does a patient and their family, how do they know for sure that they got comprehensive, complete biomarker testing?
That's a great question. So, I mentioned earlier that there are some focused panels that are doing maybe just a lung cancer panel. Now, there are different companies that are out there that do big, extensive panels, but you want to ask your provider, did we get DNA, RNA, whole exome sequencing, right? I don't know if I can say company names or not, but like those are things that you want to ask. Full next generation sequencing is another word that would also help kind of make sure that we got that. A lot of patients are just getting the panel where we get the 9 different genes that we know that are going to typically show up in lung cancer, and those are the only things that are being tested. But the problem and the shortfall for that is that if there is a clinical trial, for example, for FGFR right now, right, there are some phase 1 trials that are looking at all solid tumors, which included non-small cell lung cancer. But if they did have that mutation, they may benefit from that clinical trial.
Yeah, no, that's perfect. So DNA, RNA, whole exome sequencing, NGS, a lot of words, right? That patients are going to have to remember, but it's also an emphasis and an impetus for us as providers to make sure we're keeping up with it. We're going back to the actual reports. We're making sure that RNA was there. So I think we all have to work together on that. Another question I want to ask you, Dr. Patel, is that was all about NGS and gene testing, right? What about how we check for proteins? Because now we have drug therapies that are approved based on protein overexpression. If a patient's tumor has a lot of protein of a certain type, how do you test for that? How do you know for sure that they got that testing?
So that's a great question. So usually protein testing is going to be done by IHC or immunohistochemistry. A lot of those tests are actually run in-house for most of our academic centers. Sometimes it does still have to be sent out depending on where you're getting treated. However, those are again patients that are going to get their tumor sample sent to the lab. They will have the proteins that are the testing that will be placed on the slide, and we would be looking at how positive those are and how much the stain is expressed. And so the IHC testing is very important to help find out how expressive that protein is, because we need that protein to be expressed in order for the drugs to bind and work there.
Yeah, perfect. So IHC testing, NGS, a lot of letters, but very meaningful, right, for patients with non-small cell lung cancer. Last question for you, Dr. Patel, and then I promise I've got an overlapping one for you and Dr. Antonoff. Uh, you know, One of the problems, even in our modern day, so the big International Association for Study of Lung Cancer, IASLC, they put out a global survey about biomarker testing, right? The results were just published from 2024. And what we found is that 43% of doctors, 43% as of even 2024, are going ahead starting a treatment for a patient with non-small cell lung cancer without even having biomarker testing results available. What do you think are the barriers? How do we overcome that?
So I think one of the big issues is the time to getting your test results, right? I think a lot of times, I mentioned the frustration as a patient, right? You're just waiting. What do you mean I have to wait 3 to 4 weeks to get started on treatment? That seems silly, right? Like I have cancer, I need to get started on treatment. But waiting for that biomarker testing can be also important because it can really shape and change how we do a patient's treatment. So I think one thing is that waiting situation. And I think the other part of it is a lot of times, sometimes patients are really sick and, oncologists feel that, the need to consider starting treatment. And I think that, starting certain chemotherapies if we have to, because there's impending organ failure, sometimes does make sense. But I do think that, the access to the biomarker testing is there. Most companies have really tried hard to partner with all of the practices that don't have access to it, maybe in-house, to make sure that they have the availability. I think it's more about knowledge and continuing to create awareness about how every lung cancer patient deserves biomarker testing.
Yeah, thanks for emphasizing that. And, I think a big component of this is also just awareness, education, right? That's why events like this are super important, even on Saturday mornings, when we're all up and early and devoting our time and working together to kind of engage and empower. So thanks for that message. All right, this is an overlapping question for you guys before we invite all of the panelists back. So if a patient has stage 4 disease, they're on a drug therapy, and then they meet Dr. Antonov, they are the right patient with the right time, with the right team, and you're going to take them to the operating room. One of the things that you both have to balance and talk about from a multidisciplinary standpoint is to hold their drug treatment, right? Before surgery, after surgery. What are the pros and cons to that? How scary is that?
I'm happy to address that. So I think this also plays into really understanding which patients are at the right time for it, right? And so I always try to explain to patients that in general, we want to have control of the biology. We want to be beating the biology at the time that we operate, with few exceptions. And the exceptions are patients who are progressing on a drug therapy, and we have an operation that can get rid of 100% of their disease.
Mm.
We don't always have to be able to operate on 100% of the disease, but if we aren't going to operate on 100%, we need to be operating at a time when we are beating biology. And the reason for that is that even if we didn't have to stop drug therapy that's helpful in any setting, anytime we do any operation on anybody, we are causing trauma. And in my mind, I like to think about that as a bit of an insult to the immune system. We don't think about that, but a patient who, whether they have appendicitis or they've gotten in a car accident or any type of operation that we do, there are cells that need repair. There's tissue that needs repair. There's immune function that goes into healing from an operation. And so when we have someone who maybe is on their third line of therapy and they're progressing and they have a lot of disease sites outside of what can be operated on, that's not the person who should have surgery, because surgery is going to cause more harm than good. Most of the patients of stage 4 and are going to have surgery, we think about timing at a time when either the response to the drug has plateaued or it is peaked or whatever it may be. It's not terrifying to stop the drug. Some patients are more scared of it than I am. And the amount of time that we have to stop it is a lot of it is kind of based off guesses. We have medical oncologists who will tell us this drug is probably out of the system after 2 or 3 days. It's probably okay to stop this targeted therapy 2 or 3 days beforehand. We often in our practice stop a lot of our targeted therapies 7 days beforehand, because that's what we did on our clinical trials and we have experience with that. We also kind of, without, anecdote, just based on anecdotal experience, we put the drug people back on these types of oral drugs the day after the chest tube is removed, based on hypotheses that we think it prevents, infections from the surgical site. But those are targeted therapies, which are going to be different than things like chemotherapy and immunotherapy. And, I feel pretty strongly that patients should be off of chemotherapy or immunotherapy for a minimum of 3 weeks before surgery, ideally 4 to 6. It depends. Like if it's maintenance pemetrexed or something, 3 weeks beforehand is probably okay. But people who are getting, cytotoxic platinum-based chemotherapy, we want it to be 4 to 6 weeks. Immunotherapy that we know can cause pneumonitis, which then compounds with risk of surgery. We want at least 3 weeks before surgery. And then the biggest concern is after surgery, when people don't realize that they're still healing. Their body's immune function is still, it might look good on the outside, but there's a lot of stuff going on the inside. And restarting an oral targeted therapy agent is one thing, but jumping back to chemotherapy or immunotherapy can be really dangerous. And sometimes people get those types of drugs locally, and then they go somewhere else for an operation. And we have to ensure that communication is appropriate and that whoever did the operation is involved in any discussion about restarting any type of therapy after surgery as well. I know it was a really long, drawn out answer, but I think it's super important points for patients to hear.
Yeah, thanks, Dr. Antonov. Dr. Patel?
Yeah, I would agree and echo all of that. I think that it's really important that the medical oncologist and the surgeon are having a communication and talking about exactly what to do. I think I agree with everything she said, from starting the TKIs and stopping those, as well as the cytotoxic chemotherapy and immunotherapy. And I always try to reiterate to patients that, even though you're not getting your immunotherapy, if you were on that, we do know that there is effectiveness of the immunotherapy past that 3 week mark. And, we see effects of the immunotherapy up until 3 months later. And so just because we haven't received our dose, it's not that, we're not still doing something to the cancer. And when it comes to the cytotoxic chemos, we do want the body to have recovered from the last cycle of chemotherapy from a count standpoint, so that we are going into the surgery, at our best, so we're able to tolerate it the best we can.
Thank you both. All right. We have about 25 minutes to answer all these amazing questions that are coming in. Keep them coming, guys. I'm going to invite back Dr. Reichman and Dr. Abu-Rous to join us, and we'll get started on our full faculty Q&A. This first question I will direct to Dr. Reichman and Dr. Antonov. Are there situations where local ablation is actually going to be superior to using your forms of local therapy in the cases of metastatic cancer?
Yeah, so I'll go ahead and respond to this. But I'm interested in what Dr. Antonoff has to say as well. For ablation, it's generally considered in candidates who aren't available for other types or of local therapy, such as radiation or even surgery. So it's really a last line option. A lot of the data doesn't report local control. It's more progression-free survival. For a local control modality, I think it's pretty important to specifically report local control. I don't want to call out specific devices, but in one recent study with just 6 months of follow-up for a certain type of local ablation, a third of them got SBRT to the same spot later on. The local control with SBRT is 95%. 1 to 2% of people have short or long-term toxicities from it. But I do have a few patients in clinic who are highly motivated to avoid systemic therapy despite excessive counseling, and they happen to have a slow pace of disease. So over many years, I might spot weld, a few areas in the lung. But I get to a certain point where I'm like, oh gosh, I don't feel comfortable to treat more. I literally have just, a few patients where this applies to. And I have a rock star interventional pulmonologist, and we're talking about getting this specific technology, for that reason. But I'm a little worried it might collect dust on the shelf because, I don't want to have any patient-facing advertisement for these because folks are going to think it's the best thing since sliced bread, and radiophobia is a very real thing. And I want people to be offered the treatment that has the strongest safety and efficacy. In reality, these devices are often cleared by the FDA for, quote, ablation of soft tissue, quote, and not for treatment of cancer. So I think it's really important, if these things are being advertised to the public, that is not refusing other systemic or other modalities such as surgery or radiation. That is seeing an advertisement and going to that person that offers that. All folks being considered for ablation should visit with a radiation oncologist. I'm just going to say that frankly, and that is definitely congruent
And a
with
surgeon.
science. Yeah. So, but anyway, that's kind of my 2 cents. I think you guys can see my bias. The
Yeah.
more data there is for safety and efficacy, I think it's the more important to offer those treatments as first line. I don't care what patients choose. I just want for them to make an informed decision.
Right. I totally agree. And so I'll give you a little pushback, Dr. Singhi, on your question, because you asked about certain circumstances where it's going to offer superiority. Superiority of what, right? Like so, Dr. Reitman has pointed out efficacy. So maybe I don't think there's any circumstance where the superiority of efficacy. I simply don't. There are definitely situations where it's the only option, it's the best option, it's the remaining option. But it's just it's never going to be a superior efficacy. There may be times where it's acceptable efficacy and not in stage 4 disease. I think it's going to be acceptable efficacy for really small, perhaps, pre-malignant lesions or very small, metastases from other sites of disease. But ultimately, we have pretty expansive data showing that for once you get beyond a certain size of a tumor, surgery is a little bit more effective than radiation in terms of recurrence risk for certain sizes of tumor, certain, once you're beyond a certain number of centimeters. And that's specifically SBRT. We have other modalities of radiation that are going to work in other circumstances. But ablation doesn't even come close. And I think we've got ample data to show that. And I think where it becomes challenging is that there are individuals who care for many different cancer types, not only different cellular cancer types, but in different body parts of the body that are going to respond differently to things like ablative therapies. And so we run into challenges where, for example, someone does a great job of taking care of colorectal cancer that has spread to the liver, which responds really well to ablation in the liver. But
Right.
the lung is a completely different organ and it has different blood supply, it has different tissue density, and all of those elements are going to impact the way something like ablation is going to work. And so you asked for the patients for whom it's superior. I don't think that I can think of a circumstance like that, but there are patients who, for example, have been treated with max doses of radiation,
Right.
cannot get reirradiated to that spot. It's not safe to operate for whatever reason. Those are situations where we don't throw in the towel. We continue to look for other strategies. We add the armamentarium, and there are ways to provide ablative therapies through a transthoracic approach, meaning like through the outside of the chest, directed by an interventional radiologist, or bronchoscopically down through a scope that goes into the airway through the windpipe that can address it from either direction. But I think, like Dr. Reichman said, any patient who's being offered an ablative therapy should have the opportunity to talk to all care practitioners that may offer a different type of local therapy because it just doesn't come close to surgery and radiation in terms
Yep.
of efficacy.
Thank you both. All right, I'm going to keep us moving and turn to our medical oncologist. This is a very nuanced question. Let's say a patient has EGFR classical mutation, metastatic non-small cell lung cancer, and they're on single agent osimertinib. And they're on osimertinib, unfortunately, have disease progression. What is the best option? Osimertinib plus ADC, osimertinib plus chemo, or osimertinib plus radiation therapy? And how do you make that option?
Did you say progression after osimertinib or first line?
Progression on osimertinib. Are you choosing osimertinib plus ADCs, osimertinib plus chemo, osimertinib plus SBRT, anything else?
There is no approved osimertinib plus ADC unless they're referring to Dato-DXd, which is approved after chemo as single agent, not in combination with osimertinib. There are some trials for osimertinib plus ADCs after progression on osimertinib, such as TROPION-Lung 15, and of course there are some others. But it's really case by case. I'm interested to see what Dr. Patel has to say, but it's really case by case because whenever a patient progresses on osimertinib, I'm always interested to biopsy or at least send a ctDNA to try to understand the resistance mechanism that led to the progression on osimertinib. If it's something like C797S, which is a mutation that happens in the EGFR protein and leads to resistance on osimertinib, probably I'll stop osimertinib and move to a different modality, considering an EGFR inhibition such as amivantamab. But if it's a different mechanism of action, there are a lot of, or mechanism of resistance, there are some other things that you can do. So it's a case by case, but the options that we have, continuing OC, adding chemo, if it's a local or like an oligoprogression, we can send to Dr. Antonoff or Dr. Reichman for some local ablative therapies. We can consider adding chemo, consider adding AMI. There are a lot of options, but it's a case by case.
Thanks, Dr. Patel.
I would agree that it's case by case. I do try, if there is oligoprogression, to try and send them to our local radiation oncologist to radiate if it's only one lesion and continue them on osimertinib while looking for the resistance patterns to decide if we need to make a change to treatment.
Thanks. All right, Dr. Reichman, this one's for you. Is there a tumor size limit for SBRT?
Yeah, and I do want to comment about size, radiation versus surgery as well, just for a moment. Patients are often healthier who receive surgery, and patients with resectable disease may just have better outcomes that's not caught by staging. So we need to randomize, and it's difficult to randomize in the modern era. But in terms of size, I mean, especially for metastatic disease, there's really, frankly, no limit with modern techniques. Historically, it was limited to less than 5 centimeters, but we kind of do think of implications of dose. Back in the day, it used to be like very, very hot in the center of the tumor because that's all we could do by hand. But now we're able to kind of spread the dose out more evenly. So yeah, I would say that there's not really a limit. And then the main thing is abutment of critical tissues that might be more radiation sensitive. That's a limiting factor. The art of what we do is what are we doing at those interfaces to minimize the chances someone may have an adverse effect. So, and that's regardless of size, like really. So, yeah, I'd say there's no limit, and it's a very nuanced, like case by case decision based on location and, a number of other factors.
Thanks, Dr. Reichman. So that's a myth busted. I always thought there was like this 5 centimeter cutoff, but it sounds like that's not true now. So that's really helpful. I'm going to turn back to our medical oncologist. This is an interesting case, and I wonder how often this happens or if you've encountered this. A patient is newly diagnosed. They test positive for two major molecular changes. So they have a classical EGFR exon 19 deletion, and they've got an ALK fusion. What is the current standard of advice for starting treatment? Do you start treating one mutation first or alteration first and then switch to another? Do you combine things? What does the latest research suggest in terms of the best treatment plan?
So I would have to say that I think that this is probably a very rare occurrence. I know we see a lot of compound EGFR mutations where we might have two different EGFR mutations in patients. Again, something that's rare. I don't think that there's a standard of care here, right? I think we would be looking at, what is the variant allelic frequency? Like how prominent is that ALK fusion in comparison to the EGFR mutation to help us decide which treatment are we going to start with. I do think that, there could be considerations of combining treatments, but I do think that we have to keep in mind the toxicities and how this has not been tested and not standard of care.
Dr.
I
Bruce?
agree. So, first of all, I would confirm the presence of two mutations. So, either by sending ctDNA and or repeating a biopsy to confirm. I haven't seen a de novo or like a patient who's newly diagnosed with these two alterations. However, I've seen cases, or maybe I can't say cases, maybe case one or two maximum cases of persistence in an EGFR patient, and then an ALK fusion was quote unquote the resistance mechanism. I've seen patients being treated with a combination of osimertinib and alectinib. Some patients had to dose reduce one or two of these compounds. And yeah, and the results were really good. So I think we need to know what is the stage of that patient, and then number two, confirm, and then number three, if it's de novo versus a progression on a single targeted therapy. But combination has been used before.
Yeah, thank you both. Turning back to Dr. Antonov and to Dr. Reichman, this is a really nuanced question. I really appreciate this question from the patient or caregiver that wrote it. For using local therapy in the setting of metastatic disease, there's this thought of can we radiate or should we resect all sites of disease versus should we really be trying to understand the biology of if this is behaving like oligometastatic disease? What do you make of that question and the nuances of pulling in local therapy?
I'm not sure I totally follow. So the question is, do we need to be sure that it's behaving
Is it really
biologically?
behaving like oligometastatic disease? Let's say a patient has more than what you can count on your hand, right? More than
Yeah.
five
So I
sites of
mean, yeah.
beginning. Mhm.
So this is where we get into the controversy of whether staging really matters at all. So
Yeah.
staging is based on anatomic definitions as a surrogate for disease biology. And historically, staging was helpful because it told us someone's biology based on the volume of tumor and how long it had been there. That was what you found out by anatomy, is how long has it been there and how bad is it. But now we can not only interfere with biology, but we understand it better. And so, I mean, I would argue that the number of metastases doesn't matter. We've definitely oligometastatic disease was our breakthrough into doing, more aggressive therapy in terms of radiation and surgery. But if someone is responding in a way that shows us their biology is favorable and we are beating biology, then I think that's the window to radiate everything you can, take something out, be aggressive in that moment when we're beating biology and try to stay while we're beating it. I mean, for any of us who've spent time at our kids' sports activities, you know that once the other team starts to overcome, you just kind of give up and you hope that your kid isn't mad at the end of the day. But you want to fight while you're winning, not while you're losing.
Yeah, I think that's a great way to address that question. I mean, there's a lot to get at here. I'm going to try my best to be brief. We're still understanding pace of disease as well. For example, just because someone might have six brain metastases one year, that might not mean that they're going to have one the next year. I've had plenty of times where they have six one year, then none for many years, and then one a year later, then five, 4 years later. So pace has to do with this. And then
Mhm.
also, when we are delivering local therapy, when someone's on a medicine, the whole argument for this is whether or not it's isolated resistance in the spot that we can see on radiology. So that's like isolated clonogenic resistance is like the medical jargon, or is it global clonogenic resistance? As in, has all of it learned its way around that medicine? And so a lot of times we just have to give the benefit of the doubt. And if we believe that the treatment, the local therapy is safe, and it will be effective, then it makes sense to do, especially when folks might have limited subsequent options for medicines. I always just say, I want to keep my medical oncologist sleeves as long as possible with as many tricks up them. So, I mean, it's really complicated in terms of pace and whether or not everywhere has learned its way around the pill. And then otherwise, for example, I've had patients on KRAS inhibitors for years when we use local radiation. On the trial, it was 6 to 8 months. You know what I'm saying? And my
Yeah.
medical oncologist will say, I'm going to switch medicine unless you do local therapy. Right.
Yes.
But then I see very weird kinds of progression that's not caught on imaging. So that's where I think like these advanced biomarkers are going to really help, like circulating tumor cells to help maybe pick up things before they show up on scans. But I've lost dear friends who've had very unusual subclinical progression when we're doing local therapy and continuing the same medicines. And so I don't think we really know the answers to these questions, but I think they're critically important questions.
Yeah, thank you both. And as a medical oncologist, I really appreciate what you and Dr. Antonoff do to help us get more mileage out of the drugs that are working quite well, right, for patients. And so we really appreciate that. I'm going to go back to my medical oncology colleagues. This is now about BRAF V600E positive disease. Okay. We have options like chemotherapy, immunotherapy, targeted therapies for patients whose disease harbors a BRAF V600E mutation. But what if the patient has gone through all of those three options? They've gone through the targeted therapy, they've gone through chemo, they've gone through immunotherapy. What do you recommend? Are there trials for these patients?
So again, it's very important when we're talking about targeted therapy and driver alteration positive non-small cell lung cancer is to try to understand the resistance mechanism. A lot of times in most of these driver alteration positive, but particularly or as an example in BRAF, the resistance mechanism can be in that RAF-MEK pathway. In terms of clinical trials, yes, there are a lot of trials for what we call like pan-RAF-RAS inhibitors. So these are inhibitors that inhibit the pathway from kind of downstream to cover the resistance mechanisms that can be the reason why the cancer is progressing on these targeted therapies. So that's one type of drugs that are in clinical trials. There are other drugs that are either a newer combination of immunotherapy, sorry, like newer immunotherapies or ADCs or bispecific antibodies. So in that situation, I will definitely be looking for a clinical trial, particularly, preferably a targeted one, but there are some other clinical trials that would be interesting.
Dr. Patel?
Yeah, I would echo that. I think the number one thing right now would be advocating for yourself to find a clinical trial. I know part of the times it's really hard if you don't have a big academic institute that might be close to where you live. How do you find these clinical trials? How do you look at these things up? And, it's a very confusing thing, but clinicaltrials.gov is a great place to start. You can usually put in your mutation and your diagnosis and be able to see, like, region-wise you're only able to go, for example, I'm in Texas, so I'm only able to be in Texas. Like, what are my options? And I do think that the pan-RAF inhibitors and the ERK inhibitors are probably the things that you want to be looking at for the resistance that we're seeing in the BRAF V600E patients.
Yeah, so I'll just also emphasize repeat molecular testing, making sure that you're checking for those proteins as well if you do have progression of disease on the three treatment options that were already displayed. And there's also ADC trials as well in this setting too.
One,
So
one more thing, also look at the patient advocacy groups,
yes,
particularly in BRAF bombers. They are very well versed with, the clinical trials that are available, and they have, very good connections with experts in the field, so they can connect you with someone who has a trial either in your area or elsewhere.
thanks for that plug. Dr. Antonoff, this question goes to you. What are the exact next steps in pursuing the possible route of surgery? And is it offered at all centers? Do they have to go to one center?
So that's a difficult question. The exact next step is to have a conversation with the medical oncologist who's treating you. And ideally, they will have a collaborating surgeon with whom they can connect you. I think you need to ask for that consultation. If that's not something that can be facilitated at your own hospital, at your own healthcare system, then I think you can be your own advocate and you can look for a place to go to seek an opinion from someone who's willing to see you as a new patient at another place. These difficult operations are not being offered everywhere. They definitely should be offered at many more places than where they are. There are skilled, competent thoracic surgeons that are capable of doing these types of operations really in a wide variety of places, but they shouldn't be done everywhere. So ultimately, I think it's figuring out what works for you in terms of your resources, your ability to get somewhere where someone is comfortable doing them. I think the first place to start is with your own medical oncologist. And if you find that there are barriers, then seeking alternative options, looking elsewhere. Sometimes some of these patient networking groups are good places to turn and find out where other people have had success, perhaps in an area in your own region.
Yeah, thanks for putting a plug in for those resources. We have 7 minutes left, and we still have several questions. I'm going to open this one up for all of you, and I'm going to lump two of these questions together, so bear with me. Let's say a patient is on systemic therapy and they're getting their scans, right, to make sure that the treatment is working. And on these scans, you start to see small spots or nodules. And let's say this patient had early stage disease, and they underwent surgical resection up front. How do you know if these small spots or nodules are the cancer sort of slowly creeping and growing? How do you know if it's scar tissue? How do you know if it's something else entirely? So that's just for nodules. What about lymph nodes as well? Some mildly avid FDG lymph nodes. What do you guys do in this setting?
This is a patient who's had surgery, you said?
Yeah.
Regardless of which treatment they've had, I mean, ultimately, um, I think you want to look at the trajectory of multiple imaging studies over time. Something that was stable on and off systemic therapy was probably benign and is likely to remain benign. Something that appears, that small little nodules that appear while the primary tumor decreases in size, is likely going to be infectious or inflammatory. Lymph nodes are likely to look, all sorts of stuff happens after surgery. Lymph
Yeah.
nodes may look enlarged. Sometimes people have inflammatory changes after radiation. Ultimately, I think if someone has had a local therapy, you need to involve the clinician who performed that local therapy to see whether it's expected or not. But I think at the end of the day, it's following stuff over time and seeing what gets bigger, what gets smaller compared to other things. And lymph nodes are easy. You can do an EBIS and figure out if they're real or not.
Yeah, I totally agree. What's most important is the trend, right? I always tell my patients if a nodule shows up, is that it's important if it comes and sticks, or if it comes and stays and starts getting larger. This is where I would worry and try to biopsy that nodule. There is also an entity of like multifocal adenocarcinoma. We see that a lot. And these are patients who probably had nodules for years and years. Some nodules will start acting up, some nodules will stay, like silent or quiet for a very long period of time. And at least from what I've noticed, I don't know if there is strong evidence on that, but most of these patients have mutations in the KRAS pathway. So it's very important to keep that thing in mind that some nodules are just going to be there and not do anything. But what's more important is the trend.
Yeah, and I just want to add just very briefly, if that local therapy was radiation, it's important to correlate with prior radiotherapy fields. So that's when your radiation oncologist opinion is probably the most important because we know where and when and what dose. There's no way to overlap, at least at this time, radiation fields and delivery with the diagnostic imaging that is received in follow-up. I'm sure whoever comes up with that solution is going to charge a boatload of money for it, so it's not going to be available at most centers. So that's what I would say. I always say this all the time is I'm the quarterback of the lungs after we've pointed some radiation there.
All right, you heard it here first. The radiation oncologist is now the quarterback of cancer care here for this specific scenario.
Yes,
I
only after radiation, that's all, because we can correlate. Yeah, I just mean with follow-up imaging and preventing PET CTs from occurring because there's physical harms such as biopsy risks. There's
Yeah.
psychological harms. You still have cancer from a avid PET CT, and then there's cascade harms that can result from a PET CT too early, such as systemic therapy switch.
Yeah.
So that's what I mean. It's just about taking ownership of what we have done. That's really
I
it.
love that.
As a team, as a team.
Yeah.
The only other thing I would add about the lymph nodes is I do tend to ask patients about recent vaccinations because we do know that some of our vaccines will cause some of our lymph nodes to enlarge and also become FDG avid sometimes on our scans.
Yeah, thanks for adding that important point. Dr. Reckman, I love this question. I know you do a lot of work in this space. It's all about AI and using digital platforms to kind of help what we're doing for our patients. Is it helping right now? Are you using AI to shorten the time it takes for you to evaluate an individual situation? Is it helping with medical decision making? Is it making some of these complexities and nuances and gray zones in thoracic oncology more accessible, easy to digest by providers?
For providers, maybe. For me, it really helps insert emotional intelligence into my communication with colleagues and sometimes for patient messages. It helps me with peer review or with rebuttals when I get denied by insurance. It saves a lot of time. Actually, made the New York Times. It's an article called 35 Ways Real People Are Using AI Right Now. What used to take me over an hour takes, like a minute or two to write rebuttal letters for insurance companies. But so I wrote this digital textbook that's used by about 3,000 people all around the world every month. It's just radonc.org. It's critical critique of commentary on clinical trials. And I've tried to feed it into like Grok and ChatGPT. And the reality is, it doesn't understand the nuance when it comes to, cancer care. I mean, it gets a lot of things right, like the emotional component of care for patients. I think it's a fantastic thing to do to help come up with sets of questions to ask your oncologist, for example. But when it comes to treatment, it still kind of misses the mark. A lot of times I say that we're trying to, fit the camel through the eye of the needle, so to speak, with these really nuanced discussions we're having today. So it does require like expert oversight to see what they're recommending because there's a lot of gobbledygook, even with the references, for example, it'll make up papers. So yes, I think it's a powerful tool, but also I'd like to train it like to give better answers. But I've tried to train it and it still misses the nuance. Like I've fed thousands of pages and references into it, and then I ask it very specific questions and I give it an F. So it's largely helpful, but we should have a raised eyebrow.
Yeah, thanks for that. This is our last question, and this goes to our medical oncologist, and we're turning back to the EGFR space. So for a patient that has EGFR positive disease, we'll say this is a classical EGFR mutation, exon 19 deletion L858R, and they started on a targeted therapy like osimertinib up front. And unfortunately, the cancer starts to grow. You get biopsies, you get blood tests, and it starts to show complex patterns of resistance. An example is a C797S mutation, other complicated changes. If you have to choose another systemic therapy, what's the best option at that time? Are you reaching for amivantamab? Are you reaching for chemo? Are you pushing the patient for a clinical trial? How do you choose?
So it depends on the amount of progression, right? We can always, if it says, a localized progression, you can consider localized therapy. But for C797S and other complex mutations, probably I'll consider amivantamab, although there is plus minus chemo, or probably plus chemo per Mariposa 2. There is some evidence on combining osimertinib plus erlotinib in patients with a classical EGFR developing C797S because that mutation can cause resistance to osimertinib, but it can sensitize the tumor cells, or at least the cancer cells, to earlier generation TKI. I've used OC plus erlotinib, and it worked for actually a good period of time in one of my patients. It's this combination is a little difficult to tolerate, but with some dose reduction, you can get the patients through.
Yeah, thank you. Dr. Patel?
Yeah, I think he brought up probably the two big options that we would look at. Obviously, if it's oligoprogression, you're looking at the local therapies. I do think, amivantamab has not been the easiest drug for a lot of patients to tolerate. There's a lot of infusional reactions, and with our new data about giving steroids, people have been able to like tolerate it a lot better. But we do combine it with chemotherapy, right? And so picking the right patient for that, with the increased side effects of erlotinib plus osimertinib versus, adding chemotherapy, I think that's going to be a lot of a discussion with the patient depending on the situation specifically, but also, what is their ability to tolerate these symptoms?
Yeah, perfect.
And then
All right.
most importantly,
Uh,
sorry, clinical trials. There are some
Yes.
new allosteric EGFR inhibitors that are coming soon, either in trials or in the market, that work, supposed to work against C797S. So they'll always look for clinical trials.
Perfect. Well, we ended right on time. I really want to first thank everyone in the audience, the patients, their loved ones for being here, for spending your Saturday morning with us to engage, educate, and empower. I want to thank our esteemed faculty members for joining as well too and offering your expertise and taking time away from your families to be here and share your information and knowledge. I also want to thank our program sponsors who have been so generous, Takeda, Janssen, Daiichi Sankyo, and Regeneron. Thank you for really investing in patient education and bridging this gap in communication and education. I really appreciate it. To our audience, you can fill out Grace's event feedback form by clicking the link that's on the left side of your current screen, and then you'll get a link that will be emailed to you after the event has finished. You can also continue discussing content from this webinar on Cancer Grace's online forum if you continue and click on the discussion link also on the left side of your screen. And lastly, I know we talked a lot about non-small cell lung cancer, but I promise you there have been big changes for patients with small cell lung cancer. And if you're interested in learning more about that, stay tuned for the SCLC Small Cell Lung Cancer Onc Insight video series that you can find with Cancer Grace. Thanks again, everyone, for being here, and have a beautiful rest of your day and your week.